the lateral part of the temporal horn. So when you enter here, there is hardly any chance of getting a deficit, and this is the best entry point, and this is the operative site. Of course, for epilepsy surgery, we go in here and remove the whole neocortex along with the amygdala and hippocampus as an in-block fashion. So this is our paper on the subject. Coming to some deep-seated gliomas, so we've defined an approach for tumors in the base of the frontal brain, in the region of the frontal horn. This is a tumor of the caudate head, and this is a paper on the subject. Anatomically, if you see, you can approach it either from the medial orbital gyrus or the lateral orbital gyrus. There are no fiber bundles that come into play when you are coming from the subfrontal region. So this is the anterior commissure, which is way in the depth. This is the IFOF, which is again posteriorly. So when you come, so this is an upturned specimen. This is the frontal, this is the temporal. So when you're coming from medially or laterally, you're avoiding damage both to the IFOF. The only fiber bundle that may come into play here is the forceps minor. Some fibers may get damaged, but otherwise there is no other problem when using this approach. And it's a very good approach for these deep-seated tumors. Of course, corpus callosum, you can see that this is not a bizarre tumor. It is arising from the radiations of the corpus callosum. And these are the subdivisions, how we've divided the dorsal callosal radiations, the anterior or the forceps minor, the forceps major, posterior callosal radiations. This is the ventral callosal radiations, and the whole corpus callosum actually envelopes the ventricle in its radiations, and it also connects each part of the hemisphere to the other side of the hemisphere, and it is a really beautiful organ to study the anatomy. And for interest, it is of interest to note that it was not there before placental mammals. Before placental mammals, the anterior commissure was the main route of transmission, but after placental mammals, it is the corpus callosum. And of course, it came into play because we needed a higher speed of transmission to carry out activities. So this is our paper on the subject. Lastly, we've also studied the anatomy of the brainstem, and this beautiful image has been dissected by my colleague, Dr. Subdeep. And you can see how intricate this fiber anatomy is. And it is absolutely essential when you're to understand this anatomy before you operate on the brainstem. We've also divided the fibers of the brainstem into zones. So this is the zone 1, which comprises of the superior and inferior brachium, the superior, middle, and inferior cerebellar peduncles, and it is a safe area to enter the brainstem. Zone 2 is this area where you have designated safe entry zones where you can enter. And this zone 3 is an absolute no entry. You should not enter the brainstem from here. It has fibers of the MLF, the central tegmental tract, and it will be an absolute disaster if you do that. So this comes to the end of my lecture. For those who are interested, can read this anatomy and surgical aspects in this book. I thank you very much for your time.
Okay, so should we move on to the next speaker? Or if there are any questions, we can take probably later in the day. Okay, so we move on to the next speaker. Can you invite the next speaker, Abhida?
Yes, sir. So I would like to now invite Dr. Sushant Sahu. He's an associate professor at the PGI, Chandigarh, and his main interests are in intra-axial brain surgery. Of course, he has also some interest in endoscopy and gamma knife, but he has done a lot of work on mapping and awake surgery. And we'll hear his presentation on neurocognitive function in insular glioma surgery. Sushant?
Okay.
Thank you very much, ma'am.
I'm looking forward to hearing my dear Sushant. So Sushant, let's hear what you have learned and what you have performed in your beautiful institution of PGI. Okay, over to you, Sushant.
Thank you very much, sir. Thank you. Thank you, Dr. Avida, for your kind introduction and this invitation. So, sir, Dr. Avida has already made the job very clear because he had very clearly described the anatomical concept, the functional barrier around the insula. So, very categorically, I will be talking on the neurocognitive function and the perspective in insular glioma surgery. So the slides are visible?
Yes, very much. Beautifully.
Okay, sir. So traditionally, the insular glioma, usually the first classification came in 1992 by Professor Yasagel, who divided the insular glioma into 4 categories, where the type 3A are purely involve the insular, and type 3B are involving the frontal or the temporal opercular. Type 5A are the frontoorbital or the temporopolar area along with the insula, and they spare the major temporal structures. And in type 5B, they involve the limbic system and the mesial temporal area. However, after 2 decades, another classification came up by Sonnenberger group, who classified very beautifully by the a line drawing the Sylvian fissure and another line just parallel to the, just tangential to the foramen Monro, where the entire glioma can be surgically can be divided into the anterior superior, posterior inferior, and the anterior inferior quadrants. However, all these, the understanding is based on the anatomical structures, but we need to like understand more on the functional aspect of the tumor. The functional aspect of the tumor, we need to understand, as Dr. Abhida has already discussed and described, that this insular glioma, they usually displace or they involve the various white fiber tracts. In these white fiber tracts, the corticospinal tracts are usually displaced medially, and the dorsal language fiber, which are involving the arcuate and the SLF, they are pushed posterior, and the ventral language fiber, the IFOP is most commonly, they are pushed medially, maybe superior or maybe inferior, and rarely they also displace the ILF. With these understanding, they are not very simple to understand. The insular glioma, the symptomatology is not very characteristically is limited into the white fiber tracts. If you look at the white fiber tracts, like if the corticospinal tract is involved, the patient may develop paresis or plegia. If the arcuate fiber or SLF, the deep arcuate fibers are involved, then the patient may have some phonemic errors, and the SLF may have anarthria, dysarthria. And if like uncinate fasciculars and are involved, then the patient may have some higher semantic error. And the IFOP is, of course, it is involved the semantic error and the emotional aspect of speech. So once we consider an insular glioma, if we are considering only the tracts, we need to understand their functional aspect and their interconnection. While we are operating this insular glioma, in addition to these tracts, there are some other tracts that come into play. Like Dr. Abhida already told that from SMA, we may have the frontal ascendant or frontal striatal tract. They run just anterior to the insular glioma. While going through the frontal opercula, we may injure them. And the SMA is also getting connected posteriorly to the parietal lobule, and they may subserve some functions of language. With this understanding, and we move on to the next, that Professor Dufo has already described, that all these, the cortical and the subcortical area can be stimulated, and some of the function can be mapped during surgery. If it is possible to map all those areas, then probably we may preserve the patient functionally. So here the red marks are the primarily motor area. Where we stimulate this area, we may get the stimulus. If we stimulate the upper limb area or the face area, we may get some twitch. Similarly, if we get those negative motor mapping area, like those which are getting connected to the supplementary motor area and getting controlled from the SMA and the pre-SMA, we may get the negative motor response. And if we stimulate all these connecting the networks, then those disruption of the connecting networks, we could be able to like elicit all those like phonological or the semantic error or loss of speech and various other function that is related to these tracts and the networks. So considering all this, we first conducted the first phase of the study in our institute, where we analyzed all these like the white fiber tracts in relation to the insular glioma. Here in this first study, in the first phase, we included almost 52 patients of insular glioma, where we found that majority of the fibers are either normal or they're displaced. In very few cases, these fibers may be getting disrupted. So what we found that in these cases, like if you can see that the corticospinal tract is in majority cases is normal, and in few cases and or it may be displaced. However, in few cases it is disrupted, and even if it is disrupted, only in almost 50% of the cases, patient is having paresis because of this disruption. That could be because of the edema or maybe because of the infiltration of the tumor, which is very difficult to delineate on radiology. Similarly, for the ventral language pathways, the disruption is seen almost in 13.7% of the cases, out of which only few cases have cognitive decline. And similarly, the dorsal language pathway, and when it is getting disrupted, then patient may have dysarthria in the preoperative period itself. So it is extremely important to understand the patient as a whole, the functional aspect as a whole in the preoperative period, so that these patients can be prepared properly before surgery and can be explained the prognosis, and subsequently the rehabilitation methods can also be managed in the can also be planned in the preoperative period. with this, we analyze another study where we compared a control group of 30 patients, and we compared them with the insular glioma of 46 cases of insular glioma in the preoperative period. And we like two cognitive assessment methods which we included in our study. One is the Montreal Cognitive Assessment Score, which included visuospatial attention, language, executive function, memory, and orientation, and Western aphasia score, which included aphasia, comprehension, repetition, and naming. And we found that those patients which are in the preoperative period with insular glioma, they have significant decline in these cognitive assessment. However, majority of these patients are unaware of this, and they could able to carry out their daily performances. However, when you compare to the normal population, and various of these cognitive parameters, they are statistically lower than in comparison to the normal group. And with this, we then move on to our phase 2 study in our institute, where we analyze the cognitive and the language assessment of the patients who are undergoing awake surgery for this insular glioma, the preoperative and postoperative period, and we included only these two parameters, the MoCA and the Western aphasia score. So all these patients were operated in awake craniotomy. Usually the craniotomy is marked, it is larger than the tumor margin, so that we could able to map all these area in the it is in addition to the tumor area, so that in the peripheral white fiber tracts will not get disturbed and the function will be preserved in these cases. I'll not go into the details of the electrical mapping, but we rely on the direct cortical stimulation, and a bipolar stimulation is usually used in the surface, and in the depth, we use the monopolar stimulation to map the cortical or to monitor the corticospinal tract. First of all, we set the threshold of the stimulation. Then in the cortex, we look for the SMA and it's the connection, the frontal ascendant or the frontostriatal, where we could able to delineate the negative motor mapping response. And if we move on to the primary motor area, M1, the face or the hand area, we could able to see the twitch, which are the correspond to the positive motor mapping area. And inside the tumor, along with while move on to the resection, frequently with a frequent interval, we assess for the semantic or the phonemic error, which are corresponding to the ventral or the dorsal language pathway. So this is an example of a left insular glioma where we did the craniotomy and we could able to elicit the negative motor mapping area here and the positive motor mapping area here. However, our cortical resection is towards the temporal side, but we should be very careful while you go inside and we are trying to take out the tumor close to the negative motor mapping area. We may damage these tracts and patient may have additional deficit. So when you are close to this number one area, which is 1 and 2, they are the negative motor mapping area. So when you are going close to this area, we are always suspicious of if the patient is developing any negative motor response. And the patient is usually in this point of time, we used to assess the dual method of assessment, that is the picture naming as well as some simple motor movement. If there is some coordination in between the two, then there is some alteration is there, and we used to stop there. And if the patient is having any other functional deficit, then we move on to some other area, start resection, and again come back to this point. And in this case, as we see, this is the postoperative cavity period. The cavity is showing the complete excision of the tumor, and the post-op radiology is showing a good resection of tumor. With this, actually, for a subcortical mapping and monitoring, we rely mostly on the picture naming task. As in the left side picture, which is showing is a large insular glioma in the medial aspect, that is the IFO, which is displaced medially. When we are going close to that, we usually assess for we look for the semantic error. If the patient is not having any semantic error, if the patient is not having any functional deficit, we continue our resection till that point, till we reach up to the periphery of the peripheral insular sulcus. Similarly, if we are going posteriorly, if we are close to the SLF or the arcuate fasciculus, we look for the phonemic error, and if it is not there, we continue a resection until we get some functional deficit or we close to the insular sulcus. So this is after resection of a large insular glioma. So it has to be, if it is possible, then we try to correlate with the intraoperative imaging if it is there with the neuronavigation, so that if we are close to those tracts and if you have elicited some functional deficit, then it is very well correlated with the postoperative deficit or if it is there. So these are few of the examples where these are the last left-sided insular glioma, which is completely resected, and these are the margins where we got the dorsal language pathway. There is some phonemic error, and that was our endpoint. And postoperatively, also we found in the upper image, in the axial section, there is a very small, tiny hyperintensity in the FLAIR image, which is showing a very small residual tumor, and probably that is the endpoint of this. And the patient is under follow-up, and last almost 3 to 4 years, patient is not having any other deficit. And the right side image is showing a large insular glioma where the functional mapping was continued, and intraoperatively we could able to detect the ventral language pathway where we got the semantic error and stopped our resection, and post-operative radiology is showing a very good resection, and the patient is a math teacher and still he is back to his profession and continuing his activity without any additional deficit. At times, we also do post-operative DTI to look for if the patient is having some deficit. This patient was professionally, he was planning for some skilled works. He was like preparing for some chartered accountant, and patient was having some error in the calculation and in recall. And in that case, when you do the post-operative DTI, we found that there is some disruption of the tracks of the dorsal language pathway, which were probably they were resulted in the functional deficit in the post-operative period. Although the patient was active and the patient was not having any problem, but when he was trying to back to his profession, he faced some of the situation, some difficulty in calculation. Probably that could be explained with these tracks or their connection. So this is when we like analyze our cases of the phase 2 study of 52 cases of insular glioma, we found that in the post-operative period, patients have a significant decline in the immediate post-operative period in attention and working memory, executive function, orientation, and in the Western aphasia score, we found that there is deficit in aphasia, spontaneous speech, and comprehension and naming. However, majority of these deficits, they improve after 3 months, and majority of these patients are back to their profession after almost at a period of 4 to 6 months. So after understanding all these, the functional activities of this, the tracks and their connection, then we move on to the phase 3 study in our institute, where we analyze the extent of resection of insular glioma and the functional deficit. Because in many of the cases, Dr. Abhida has already shown that some of the tracts are displaced, but some of the tracts are infiltrated. As this image is showing, this is the corticospinal tract that is getting infiltrated by diffuse left insular glioma, and intraoperatively we could able to elicit motor response when we entered into the glioma, entered into the tumor, and intratumoral activity is detected, which is very rare. And this is already published in our case series, and in almost 2 or 3 cases out of 100 cases, we found that intratumoral these tracts, and we have to be extremely careful. So after this analyzing these cases, we also design another study that whether this extent of resection is correlating, how it is correlating with the functional activities of the patient. And in this case, we have included, in addition to MoCA and Western aphasia, we have also included hospital anxiety and depression scale and the patient assessment of own functional inventory. This own functional inventory, this is based on the recent activities of the patient. Patient will remember and patient will recall the activities, and patient will try to correlate, so that the peri-operative period assessment will be very, very effectively assessed in these kind of patients. Here in this case, we included 71 cases of insular glioma operated in last 4 years, where the occupation of the patients were categorically analyzed, and the patients were followed up very carefully and analyzing all these factors. Majority of the patients were having skilled job, so our aim to have a proper functional recovery in these kind of patients, so that they will be able to back to their profession. Like in this case of a large left insular glioma, so the patient was operated with the same manner, with the same assessment scales, with the assessment of the cortical mapping and the subcortical mapping and monitoring, and we could able to resect the entire tumor, and the patient is back to his professional life, although he has subtle deficit in the immediate post-operative period. In the lower image is also showing a large grade 3 astrocytoma, and the patient was operated and the tumor is completely taken out, and considering all this functional activity intraoperatively, and where we detected those functional activity, or if we could not able to detect, then we continue our resection till we reach up to the peri-insular sulcus. And this is another example where the tumor is completely resected and the patient is followed up closely. So in this kind of resection, where we could able to achieve more than 90% of the resection, we found that we could able to achieve more than 90% of resection in large insular glioma in 16 of our 71 cases, which is around 22.5%. Here we found in the immediate post-operative period, patients have functional deficit in terms of executive function and language domain, which is statistically significant. In addition to it, in other domain of the MoCA has also reduced in the post-operative period, although it was not statistically significant, and anxiety and depression scores were also although it is not significant, but still it affected the patient, and of course the patient assessment score was also lower. So when we stopped in between, like if we get some functional deficit in the patient intraoperatively, like in this case, when we are going posteriorly, we are close to the the dorsal language pathway. And when we are close to the dorsal language pathway, when we elicit some phonemic error, we stop. And the postoperative radiology showed a small size of tumor and a small residue, and the patient was under regular follow-up, and it turned out to be a grade 2 astrocytoma. Similarly, in another case of a large insular glioma, right-sided insular glioma, intraoperative only patient had a significant cognitive decline. So we'll have to stop in between, and we stop the surgery. And we found that in the postoperative radiology is showing some amount of residue, and the patient is under follow-up because the patient had some intraoperative functional deficit. And when this is another case of a large insular glioma, which is going into the involving the limbic system and going up to almost, it is like pushing the thalamus. So when we tried to resect the entire tumor, we could not able to resect the entire tumor. When we are going posteriorly, patient has significant cognitive, the language deficit were found, and patient has naming error, and the cognitive decline was detected. So the resection was stopped. In these kind of cases where we found intraoperatively, the patient has cognitive decline, and even with that also, we tried to resect some amount of tumor. We could not able to reach a complete excision, and still the residual lesion is almost 10 to 20%. This kind of near total excision, we found that in this category of near total resection, we have almost 47.8%, that is 34 out of 71 cases of insular glioma. Here, the deficit in the immediate postoperative period is higher than the gross total excision. Probably we are attempting to resect more and more when the patient was having some functional deficit intraoperatively. And we found the visuospatial attention domain and the total MoCA score were significantly lower in comparison to the pre-op period. And similarly, we also found that the aphasia score was also significantly affected when we attempted to operate more and more when the patient has already developed some functional deficit in some domain of the language. And although these symptoms improves in the postoperative period, but in the immediate postoperative period, patient has this kind of deficit. Another category is that when we found that the patient if develops some sort of deficit, like some language error, then we stop immediately, and we stop there and move on to some other area. If the patient is having some deficit in some domain of the language, then we stop. Like in this case, the patient was a school teacher, so he was very anxious that all the domain of language, calculation, and all the naming, everything has to be intact in this case. So we are very cautious as going posteriorly, and as we're going towards the ventromedial area, here the IFOF was lying, and when we elicited some semantic error, then we stopped. And in the postoperative period, we found that there is some amount of residue is still remaining, and the patient is under follow-up almost 3 years after surgery. The tumor is almost similar. In similar kind of cases, the patient was operated by us only 5 years back, and the patient had significant language deficit intraoperatively. As you can see that we entered into the medial part, and we found that probably we have injured we have stimulated the IFOF area and the corticospinal area. Probably the patient had some deficit, and we stopped there, and the postoperative radiology was showing a significant residue. The patient was under follow-up for 2 years, and after 2 years, patient was again prepared for surgery, for a redo surgery. And in the redo surgery, we found that there are some hyperintensity already there in the flare, but we focused on the tumor only, and considering the language and the cognitive assessment, we rely on that, and we continue our resection till the patient is having some functional deficit, or till the patient will develop some language error. And with this, we could able to resect the residual lesion here, and the patient is completely intact in the postoperative period. So in this phase 3 of subtotal resection, we found that those cases where we stopped, where there is some functional deficit while operating on insular glioma, and we stopped and we left those areas, then in this kind of patient, they usually do not have any statistically significant functional deficit cognitive decline in the postoperative period. Here, in these 21 cases of 29.5% of our cases, where we did a subtotal resection, planned subtotal resection, where we elicited some functional deficit in the postoperative period, in the intraoperative period. So in the postoperative period, none of these patients have statistically significant functional decline, although the functional status in all these aspects are relatively lower in the immediate postoperative period in comparison to preoperative period. So this is our phase 3 study, just completed 1 month before in December 2024. So we are following all these cases, and we are also trying to evaluate all these patients after 6 months. And we are looking forward, if with this functional activity assessment, if the patient is having some sort of functional error, if they are improving after 6 months or not. So And this is a beautiful example. This patient was a young female. She was a dancer. So we are quite apprehensive that that should be all movement has to be preserved and all the skills has to be preserved and hand-eye coordination has to be preserved. So intraoperatively, we did some like the numerical testing, and intraoperatively, we continuously assess for the motor areas as well as the language. And we could able to like resect the entire tumor. The patient was not having any complaint in the post-operative period, but when the patient is back to her profession, she could not able to perform. She had severe anxiety because she developed some sort of like recall issue. And when the patient was put for the language deficit test, then the neuropsychologist found that there are some error in the cognitive decline. The patient has some recall error is there, some memory deficit is there. So probably there are certain like interconnection in the insula is there. Yeah, that is beyond the understanding of the white fiber tracts. We need to assess them, we need to address them so that all the patients could be able to back to their professional life. So this is out of these 72 cases, what we did that this is almost 39% was having skilled job, and the result which we got last month, that we found that almost 50% of the patients were able to back to their professional life with the same cognitive status. However, almost 22 to 30% of these cases, they took some time to improve. They could able to back to their professional life. However, some 10 to 15% of the cases, they could not able to back to their professional life. So this is the time that we should analyze more and more, and beyond these white fiber tracts and beyond this interconnection, we have to analyze all these cases. We have to closely observe all these cases, and we have to analyze all these functional status so that we could able to understand more and more in insular glioma. So to conclude, for insular glioma, the insular glioma may affect several domains and subdomains of cognitive function. The postoperative cognitive assessment usually helps in understanding the functional status of patient and the possibility of return to their skilled job. A better understanding of the cognitive function may further help to unfold the brain connectomes beyond the structural anatomy. So if we can understand this, then we may be able to customize the functional assessment scales, and we could be able to like analyze all these patients with that individual scale, and we can also like design some of the rehabilitation for these patients so that all the insular glioma patients can be back to their professional life. Thank you very much.
Thank you, Sushant, for that wonderful and impressive lecture. And you have, over the period, you have developed quite a big and beautiful experience. And I really congratulate you for what you have done and what you have achieved and what you have thought about this complex subject of insular gliomas. As you know, and as we all know, surgery on insular gliomas is not simple. Surgery on insular glioma can be wrought with various complications and possibility of huge deficit. So under the situation, to properly analyze, to properly conduct, and properly achieve your target requires a lot of dedication, hard work, and persistence and patience. And what you have done is you have shown all these things beautifully, and I congratulate you. And I wish that you continue your work on this subject, develop a strategy, and promote that strategy and present that strategy to the world as to how you remove. Most important thing that you might have and you could have included in your presentation was how you do these things. What is your surgical strategy? How you enter into the tumor? How you protect the blood vessels? How you protect the adjoining area? What kind of strategy for monitoring? A little bit elaborately, if you could have presented, that could have helped. But all in all, Sushant, I did not know that you have achieved this level, and I congratulate you. And if there is any question from the panelist or from the audience, I will be happy to have it at this stage, or maybe later in the day, and we will have Sushant here, and I will not let him move from here. Okay, sir?
Yes, sir, of course. Thank you, sir. Thank you very much.
Okay, so we can move on to the next presentation. I would like to invite Dr. Rupesh Kumar for his talk on pineal region. Dr. Rupesh is the Director of Neurosurgery at the MGM Healthcare, Chennai. And as we all know, he has a vast experience in endoscopy, in skull base, and now he's going to talk on pineal region tumors.
Thank you, Goel sir, and thank you, Dr. Abhida, for this invitation and this wonderful initiative on Neuro-oncology Masterclass. Two excellent lectures before me, Dr. Abhida on anatomy of the white matter tracts, and then Dr. Sushant sir, who has a brilliant talk on insular gliomas. And now I have a challenge now to match them. And so I think I'll do justice. I have chosen this topic, pineal region tumors, because this again is one of the very complex locations in our brain and very deep-seated. And we see that pineal region is one of the geometric center, we can say, of the whole brain. If you take the brain as a circle, it is almost the center. So not much tumors occur in this location. They're not quite common, unlike the surface tumors. But the issue in the pineal region is that the heterogeneity of lesions. So if we know that in this particular part of the brain, these tumors are common, 1, 2, 3. In pineal, we can never be certain because the tumor heterogeneity. It can vast from a pineal region tumors itself, like pineal parenchymal tumors to gliomas, to various other uncommon tumors, the germ cell tumors. So one can never be certain preoperatively or radiologically that we are going to deal with this case. So that is the challenge in pineal region tumor. And pineal region tumors have the anatomy is quite distinct. Is that it's surrounded by the venous structures, the deeper structures, the brainstem. So it's a very, very complex anatomy. So the objective of managing these pineal region tumors is number one is that majority of these tumors produce hydrocephalus. So managing that, establishing the pathological diagnosis, as I was mentioning, because of the various pathological lesions here, one need to be very ascertain that this is the lesion before we contemplate on further treatment. The surgery itself is challenging these locations, considering the depth, the vitality of the structure surrounding it. And so these are the objectives of management. If we come to the anatomy, the main challenge what we face when approaching this pineal is the deep venous structures. So we have the confluence of deep venous structures, the internal cerebral vein, the perimesencephalic vein, which join to form the vein of Galen, which drains into the straight sinus. So that is the main. So most of these tumors, we have to work around these venous structures, and any damage can produce significant morbidity and including mortality in patients when you approach these. In addition, we have the brainstem, the tectal plate, the superior septum vermis, and superiorly the corpus callosum splenium, which is one of the most important structure among the corpus callosum entire. So considering this anatomical location, and so now if a tumor presents itself as a small lesion with a huge hydrocephalus, probably I think a minimally invasive procedure like an endoscopic ventriculostomy and biopsy, achieving the pathology, and then we can plan of what will be done. And then based on the lesion, if it is a germ cell tumor, probably we can subject them for adjuvant therapy, or if it is a benign lesion, we can follow up if it is a very small, or if it is malignant benign. So a lot depends on what the lesion is. So we have to manage both pathological as well as the hydrocephalus in these patients. Doing a biopsy endoscopically, there was one challenge that they can sometimes bleed, and it can be a very catastrophe. And sometimes we may have to spend hours indicating the fluid and cavity to prevent these type of complications, but they do occur. We need to be aware of. So based on the pathology, now we can probably plan. If it is a germinoma, then we know that adjuvant therapy is beautiful. We can manage these lesions without microsurgical excision. If it is tuberculoma, again, we can manage them with medications. So that it's very important that we know the pathology, and this can be simply done by an endoscopic approach. However, at least 80% of these lesions do need surgical excision, and a lot of approaches have been described. 3 more common are the supracerebellar infratentorial approach, which is from below, the modified Poppen, the occipital transtentorial approach, which is from above. Sometimes we may have to combine both in large tumors, or sometimes we may have to come a little bit more anterior, the transcallosal, and preventing damage to the splenium. We have to come anterior to the splenium, callosotomy, and then enter the tumor. Rarely, we can also approach laterally. And so I will probably describe these in the course of my lecture. Supratentorial approach, supracerebellar infratentorial is one of the important workhorse, and we know that we work superior to the cerebellum. One can operate these patients in the sitting position or in the concorde position. The important structures you come across are the not much important structures, but some veins which can bridge the superior cerebellum to the tent, which may have to be sacrificed and to go inside. And the precentral cerebellar vein is probably one vein which we can take, so that most of these tumors are anterior to that, and dividing this vein can give a good approach, and without much problems we can sacrifice this precentral cerebellar vein, which is the only vein which can safely sacrifice. And so depending on the surgeon's comfort, we can plan either a concorde approach or a sitting position. But the key is that the transverse sinus, both and the torpor has to be exposed, and also the upper part, so that we can probably tent. We can make the tentorium incision, and then we can make it reflected the dura anteriorly, so that the structures doesn't impede us. So that is very important. The exposure is very, very important in these approaches. So this is a young girl who had a mild upward restriction. And this is so we were not sure about this pathology. The parents were quite anxious because they're doctors, and then they had this enhancing lesion, and it could be anything. It could be germ cell tumors, or it could be malignant. So we were very apprehensive. So we had to do. We cannot do endoscopically because there's no hydrocephalus here. There is stereotactically, it's very, very risky place to go because we know that the veins, it's a blind procedure, we may injure. So we decided that we'll take up, and it was quite favorable. And we can see that we thought we'll go supracerebellar infratentorial approach. I just take you through videos, a glimpse of this video. So taking down these small veins which can bridge, and then we open the arachnoid. The arachnoid of this supra is very, very thick. So the anatomical description is very important, delineation of these important veins. So as we do track this superior part of the vermis, we go, this thick arachnoid has to be open, and then you see this beautiful venous structures. So that is the precentral cerebellar vein, which I was mentioning, which joins into the vein of Galen, and we can see both the internal cerebral vein, the mesencephalic vein. So this vein can be coagulated without any major issues, so that we can reach. Otherwise, we'll not be able to reach the lesion. And as we open the arachnoid more laterally, very, very important that the whole anatomy is described, is delineated, and try to work extra-arachnoid. Try to open up all the arachnoid there, and this lesion being a small lesion, but will not enter the capsule to prevent dissemination or seedling, will go around and try to take it out in mass. So this is the superior aspect. As we see, we are doing sharp dissection from the surrounding arachnoid, small perforators which can go to the brainstem has to be preserved. And then as we go in, so we enter into the posterior part of the third ventricle, so that we know that that is the anterior most of the limit. Then we try to rotate the tumor and then try to lift the tumor off the tectal plate. So as we see here, it's a good plane, and we can see that slowly we are shrinking the tumor, but then we are not doing internal decompression. We wanted to remove this lesion en masse because this is not a very big lesion. So we try to remove this tumor as progressive, and we can see that is the attachment and from the pineal region. So we try to detach the tumor from the pineal region, and as we do so, we are opening into the third ventricle more and more, and we can see, so that is typically the posterior part of the third ventricle, and then we try to rotate this tumor and then come around and try to remove this lesion in around it. So that is the structure where it is getting attached, the pineal region. So we again go around, rotate this tumor, and then we are removing this tumor en masse without opening the capsule, thereby we avoid. So that is the attachment origin of the lesion, we coagulating it. So this is a cross-total excision, and we can see that the third ventricle is seen, and that is, you can see that not retractors were not used. Our section acts as a dynamic retraction, and then we work out, and we can see that this is the pineal parenchyma grade 2 lesion, post-op MRI, complete excision. So not much of adjuvant therapy is required, and you can see that children follow up. This is quite challenging. Here it is an epidermoid tumor of the quadrigeminal cistern, and we can see that here the tent is quite steep, and you can see that, and so one can argue that these tumors can be approached by the Poppins approach or the intrahemispheric, post-intrahemispheric approach, and then open the tent here. However, we decided that because this is an epidermoid and he had a very long neck, we thought we will still go ahead and do a supracerebellar approach. Again, so this video, so I'm just skipping this video. This is just the final portion. In the epidermoid tumors, it's very important that we try to remove the capsule. If we just do internal depulcration, then we have to follow these patients because they can do definitely recur after a period of time. So as safely and as much as possible, this arachnoid has to be removed, and then only we can prevent recurrence. Otherwise, they are completely curable diseases. So as we see, there's a good approach, not much retraction is used, and then this lesion can be completely removed. And we can see that the glistening arachnoid of the quadrigeminal cistern and complete excision is possible, and that is the postoperative MRI. So sometimes, even if it is not very steep, if it is a long neck, we can still do a supracerebellar approach. This tumor, without any doubt, it's a supracerebellar is quite good, and because the tumor itself has created the space, it's quite a big tumor. And so as we decompress the tumor, though the tumor is large, we can be able to preserve. And as we go supracerebellar, we'll be able to devascularize the tumor also, so that the tumor can be removed comfortably without any major issues. So this is a meningioma, and that is the post-op CT. We can see that is the trajectory, and so we can go ahead. Pinealoblastoma, sometimes they can go inside the third ventricle and they can remain a challenge. And again, endoscopic biopsy and third ventriculostomy, and then followed by adjuvant therapy. But however, we still know that if it is not much disseminated, a safe maximal resection can help in improving the outcome. So we try to resect this tumor. again. So however, again, you can see that this is quite deep, this is quite challenging, but then as the tumor gets decompressed, we'll be able to give more and more space, and that is the postoperative MRI, again, supracerebellar approach. A small residual disease was left, which is attached to the vein, intercerebral vein, which could be dissected, and this patient is sent for adjuvant therapy. Again, tectal gliomas. Tectal gliomas are good lesions to go supracerebellar infratentorial approach. As you see here, this is quite very favorable. And the only problem here is, as we go down, sometimes it may be challenging to see the inferior most aspect of the tumor. But however, as we dissect the tumor more and more, we'll be able to achieve to see what it is. So as we see here, so I'll just go quickly to the video, and we can see that the arachnoid is quite thick. Again, the precentral cerebellar vein, so the same approach. So as we do the opening of the arachnoid, the tumor comes into view, and then we can start decompressing this wide arachnoidal opening to see, and we can do decompression. So this is a soft tumor, as we see the T2 is white, it's a hyperintense on T2. That means that we know that it's going to be a soft tumor. And so as we decompress, it cues up. So not much effortlessly, we can see that the tumor can be decompressed, and once it is done, we can see that the whole tectal plate can be reconstructed like this, and we can see that the whole tumor has been removed, and we can see, we'll roll over and see that the tectal plate has been reconstructed, and that is a post-tumor resection cavity. And that is the postoperative MRI, as we see here. So almost a gross total excision could be achieved. A small residue can follow up these. Most of these tumors are pilocytic astrocytomas grade 1, and we know that they need to be just on follow-up. Tegmental gliomas of the midbrain again can be approached to the same. It's quite a large tumor. Enhancing, again, it is a pilocytic astrocytoma. We can see that almost the bisecting the midbrain, it's almost reaching the anterior intercrural cistern. So again, the same approach, we can see that it's a gross total excision, and we can see that. So this is the corridor, and we could achieve a gross total excision, and the patient initially had a tough time, but then he improved after 3 months to significant independent level. Cavernomas in these locations are quite uncommon, but still it's possible, and it bled, and the same approach can be used. And once we can do evacuation to the hematoma, then we'll be able to roll out, and the whole tumor can be excised. These tumors has to be excised in toto, otherwise they can recur. So you can see after the resection, we can see the nice arachnoid. The arachnoid is preserved, and all the perforators and all the brainstem all are intact because the arachnoid is preserved, and that is a postoperative CT scan, and we can know that they are all good approach. We can see that the whole venous structures are in place, and you can see. So the slight modification of this approach in the lateral supracerebellar, instead of going in the midline, sometimes we need. I think Professor Goyal sir has published this work on lateral supracerebellar approach. And so here, again, we work tangentially in the oblique way. And here we need not disturb the precentral cerebellar vein because we can work anterior to that. And this is going to be the corridor. And sometimes large lesions like this, which can be approached by a lateral supracerebellar approach. If necessary, we can also open the tent. I just quickly go through this video. Again, we can see how thick the arachnoid is posteriorly. And as we go, and we can see that is a tumor. The tumor comes across. The tumor quite big, so it itself can provide us the corridor. And we can see that that is the final tumor. We can see that this also is a good approach. Instead of coming medial, we are coming lateral. And again, it's a wide approach. As we go, initially you may be claustrophobic, but as we remove, we can get a good approach. And the tumor itself can give us a good corridor, and that is the postoperative resection cavity. And we can see that is a postoperative MRI, and we can see that all her oculomotor movements are preserved quite well. Coming to this occipital transtentorial approach, which is a Morgan-Poppins approach, and it is quite good. It is tumors going more lateral instead of midline, and also if the venous structures are displayed inferiorly, we can cut the tent, and then we can work, and also we can have a very good approach, especially if it is a larger tumors with more supratentorial extension. This is going to be a very good approach. So here, this is a 43-year-old female. We can see there's the lesion, though it is not strictly in the posterior ventricle, it was actually an immature teratoma. And we can see that it was like a pedunculate lesion. The tumor has projected itself and in between this space, and it has presented anterior. I think supratentorial approach itself is a good approach. And this is going to be, so here there's no need of any manipulating of the neck. We can place these patients in the neutral position of the neck. And this is the immature teratoma. We can see that the whole tumor is excised in toto, and the tumor itself has created the way. We need not create the corridor here, and it's given benign disease and similar locations here. So this is a very interesting case in a 64-year-old male. He was operated 20 years back for an epidermoid of the posterior third ventricular region. He was operated by none other than Professor B. Ramamurthy in his institute. And then this patient was quite asymptomatic. And imaging was not done because he was lost for follow-up. He presented to us almost 20 years later with the scan. So we were puzzled as to what it is, and though it was an epidermoid, but here the lesion was enhancing on contrast. and a lot of edema was there. We were thinking whether this is a late onset recurrence, probably it is infected, that is why it is enhancing, or it is altogether a new pathology. We were quite confused. Again, here, which approach? We can see that the 1/3 of the lesion is only below, the 2/3 are superior to the tent. So we decided we go Poppins approach, and this was our approach. As we see, we could achieve a gross total excision here like this, to a surprise, and this was turned out to be a squamous cell carcinoma. So leaving behind epidermoid long-standing can result in squamous cell carcinoma transformation, and this patient was this is a moderately differentiated squamous cell carcinoma I'm seeing his first time, and then this patient was adjuncted for radiotherapy. He's now almost 2.5 years follow-up. He's doing well. And so one need to be very, very careful in long-standing epidermoid tumor, then there's a possibility. And this is his recent MRI. We can see that the almost a good excision and no rescue recurrence, and he's on follow-up. And this is again a very interesting case in a middle-aged female, and she had this type of lesion. We had seen that the internal cerebral veins were like sort of bisecting the tumor, anterior, superior, and inferior, and it was enhancing on contrast. We had a lot of discussion what is this type of tumor, because radiologically it was not fitting into any of these prototypes, and so we decided we go supratentorial, the body fat Poppin approach. There is a straight sinus, so opening of the tent along parallel to the straight sinus. And one need to have navigation because they're not very big lesions. So just to know where we are, we can use navigation, and we can see that after the opening the tentorium, navigation helped us because we couldn't see the lesion initially. We were not sure whether our trajectory of the tumor was right. So we used navigation here to identify opening of the arachnoid. We could see that the veins, the large venous structures. So once we were quite lost here, but because we were not sure where the lesion here, because we couldn't see, we could see only the venous structures here. But however, luckily, the navigation helped after opening up the arachnoid further widely, and we could see that the pia was thinned out pia. We could see using navigation, we opened it up, and we could see that just going through it, you can see. So we spent initially a lot of time in exploring where it is, because we could see only normal structures, and then we missed this lesion arachnoid, so we opened up the arachnoid, and the tumor was actually located here, and with the help of navigation, we could reach the tumor. So these small tumors sometimes can pose challenge to us, and opening up, so that is the key. Opening up of the arachnoid is very, very important. If you do a limited arachnoid opening, sometimes we may get lost, so we need to be very, very careful again. And in the initial period for young neurosurgeons, the navigation can be of great help to reach these lesions and to know that anatomy. So that was by navigation, we could find out that was the opening. So the pia was thinned out, and we can see that the jelly type tumor, initially we were not sure what this type of tumor it is. So we can see that initially after opening up the capsule, we opened up the jelly material came out, and after the jelly was removed, so we can see that this was the calcification. It's quite hard tumor there, and it was below, so we can see that the veins were all bisecting. So these veins were displayed anteriorly. So we went around, and then we tried to decompress this as much. This was the calcific nodule, and further solid components here we can see very hard tumor. So we went all around and removed this tumor. We can see that identification, and we could achieve a gross total excision. So this is the third ventricular opening after opening up of this tumor, and we can see the navigation. We just kept confirming ourselves with the navigation. And this is the postoperative, immediate post-op MRI. And we could see nicely that the internal cerebral vein was preserved well. And this is the supra and infra below the vein and above the vein. To a surprise, this was quite a very rare tumor. So this was because of the myxoid material. And this was the gross histopathology. And we did DNA methylation study. Dr. Shushma, a pathologist, helped us in tracking out this. This is a very rare desmoplastic myxoid tumor, SMART, B1 deficient. And then there was not much of literature available. We had a discussion with Dr. Jalali, and this patient had been administered proton, and she's now 2 years follow-up. She's doing very well. So sometimes these rare tumors can be occurring in these locations. And these are some of the combined upstairs. You can see such huge tumors, quite challenging. Not one approach can take care of these lesions. So here we have to work both above and below the tent. And so this is the incision what we place, a combined approach. So we open up the things. So for a want of time, I'll quickly skip this video. And this is the postoperative MRI, and we could see that. So both we opened below and above, and this is the patient post-op. The Preoperative syndrome, in fact, was recovering, and then this patient underwent adjuvant therapy because he had a small residue, the anteriormost part. It is a pilocytic astrocytoma, and he's doing now 4.5 years follow-up. He's doing well. Again, a similar large tumor operated elsewhere, significant residual disease, and we can see that not much one approach can we remove these tumors combinedly. So again, the same approach, both supra and infratentorial approach, and this was the location, and we can see that Tony is doing quite well. And it was a mature teratoma, and he's doing well. 6 years follow-up, and we can see that he's doing well, and he's back to his normal life. Sometimes, rarely, you need to have lateral approaches. As you see here, this is again a large tumor, and this is again a large teratoma, mature teratoma with rise ICP underwent shunt elsewhere. And we use this approach because lateral approach, because we can see that the tumor is projecting more laterally, and we thought we'll get around this tumor. And this is the tracked immediate postoperative MRI, and we could see that it's quite a large tumor. The whole tumor could be removed using this approach, including and here. Because we have removed this tumor, it is benign, so we didn't give any adjunct therapy. So this was the 3 months follow-up MRI, and then this is 2 years follow-up MRI. Is doing well, and he had a sorry postoperative with a lot of seizures, even preoperative period, but then he's now almost near normal. Sometimes, rarely, this is my last few slides of the intrahemispheric approach. Especially these tumors goes inside the deep ventricle. We cannot approach from posterior or lateral. We may have to come anterior to the splenium and then do a callosotomy, and then this reaches tumor. A tumor something like this, which is more anterior, is very difficult to come posterior or lateral. The best is to come intrahemispheric. In front of the splenium, we can do small limited callosotomy and get in using the navigation again, the subchoroidal or the transchoroidal approach. Again, I skipped this video, and we can see that. So. And this is again a similar example of a large tumor. We went to the same approach. It was quite difficult to come either way because splenium was here. We couldn't come from posterior. So anterior transcallosal approach in front. And again, I skipped this video. And this is the immediate postoperative MRI. And this is the trajectory as you see that this lesion could be completely removed. So again, similar locations. Rarely, sometimes we can go anterior intrahemispheric, and this is one such lesion. Though the lesion is going up to the posterior ventricle, the tumor had created a corridor, so we went, instead of coming from behind, we went from anteriorly, and this was a trajectory, and we could remove the whole posterior ventricle and turn to be germinoma. So complications in pineal region surgery, the major feared complication is the tumor bed hematoma when it achieves excellent hemostasis, because these are sometimes malignant lesions, they're very vascular, and the residual tumor, if you leave behind, can bleed. Impairment of eye movements can sometimes be worsening up in the immediate post-op, but they do recur after a period of time. Visual field deficits, especially if you're doing a pop and approach, then we need to be careful about retracting the temporal occipital lobe, and one should not disconnect the splenium because disconnection syndromes can cause a significant morbidity. So to conclude, pineal region tumors, the approaches should be influenced by the location of tumor, the extent, and of course the comfort of the surgeon. And a tumor situated in the midline, essentially, and the veins are displayed above. I think the supracerebellar approach is good enough. If the tumor is significant supratentorial, and then the tumor has more lateral than posterior modified Poppins is good enough. And deep inside the third ventricle, I think the anterior intrahemispheric transcallosal approach. But Goyal has already described oblique approaches for these tumors, and then lateral supracerebellar is also good enough, and completely lateral, like the tumor which is showed, that also can be done. Sometimes if this hydrocephalus tumor is small, we can just do a ETVA biopsy, and then we can plan based on the pathological. So thank you very much for this opportunity. I'm okay for the questions.
Thank you, Rupesh, for the beautiful, beautiful lecture. Like always, now you have become one of the, the lectures to look out for. The techniques that you have shown, the kind of work you have shown, the kind of numbers that you are showing more recently, the complexity of cases and the approach and the technical nuances and the technical beauty that you are showing. I'm really proud of you, Rupesh. And you are the torch bearer, and you're the future of Indian neurosurgery. I have no doubt about it. And I wish you all the best. You take the torch ahead. What you showed was beautiful. I know there will be several questions and several things that people would like to. Abhida, you have some questions for Dr. Rupesh?
So there are a couple of questions in the chat. So one is what criteria you take into account whether to go supra or infratentorial, and when do you go contralateral?
So as I was mentioning, if the tumor has the bulk of the tumor is below the tent, and if the veins are displayed superiorly, supracerebellar approach is a very good approach. And either we can approach from the midline or from lateral as an oblique approach. However, if the tumor is more than 2/3 of the tumor, if it is above the tent, and if this has lateral, then I prefer to go supratentorial approach. So that's how I decide. Contralateral, if it is midline, is not a problem. Contralateral approach, if the tumor is quite large, as better to go ipsilateral because bulk of the disease, because it becomes a little difficult to go. But oblique approach, especially like a lateral supracerebellar approach, then we can actually go lateral because we'll have a good long tangential view. But I prefer to do ipsilateral because majority of the time these are deep-seated and it's quite comfortable to do ipsilateral.
Thank you, Rupesh. Yeah, I think even we prefer the ipsilateral approach rather than contralateral, even though it was first described by Sir, a contralateral approach, but we are also doing majorly in ipsilateral. So I think we'll move on to the next talk. Dr. Vivek is having some connection issues, so he'll go next. Now, I'd like to invite Dr. Ali Asghar Moyadi for his talk on the art and science of glioma surgery. Ali is the head at the Tata Memorial Hospital in Mumbai, and he has been the leading person to promote neuro-oncology in India. He has a huge experience in ultrasound, and let's see what he has to talk about glioma surgery. Ali, you're muted, I think.
Is it better now? Can you see?
Yeah,
can you
yeah.
hear me? Yeah,
Yeah,
okay. Thank you, Vita. Thank you. And thank you, Dr. Goyal, for this opportunity. And thank you for promoting neuro-oncology on this platform and across the world. So in this talk, I'm going to actually cover competency building for neurosurgeons in neuro-oncology as a specialty, and touch upon various aspects of skill sets that neurosurgeons need to have in order to implement neuro-oncological practice. So I would say that, I'm sorry, does it move? Yeah. Okay, so a neurosurgeon has to be more than a surgeon when it comes to neuro-oncology. And I would say that a neurosurgeon needs to be a neuroscientist as well as an oncologist, because it's important not just operating on these tumors and gliomas specifically, but to understand their biology, to understand that there are multimodal options on the table, understand pros and cons of each, and of course have a team-based approach, which is epitomized by tumor board discussions and multidisciplinary joint clinics, which go into making an optimal decision. But I will focus more on the skill sets that a neurosurgeon needs to have. So starting with the biology of gliomas, I think this is something that we all have been taught and are aware that gliomas are diffusely infiltrative. And there are different types of gliomas. They come in different shapes and sizes. But when we talk of gliomas as a group, and they are defined by their diffuse or invasive nature, and that is why they are described as diffuse type of gliomas, both adult and pediatric, and this is as per the WHO 2021 classification. And they are distinct from what is described as the circumscribed gliomas, which largely includes a lot of benign tumors which occur in pediatrics and young adults. The tumors may appear radiologically circumscribed, and often that's paradoxical, but studies have shown that the diffuse invasive glioma cells pervade and infiltrate far beyond what is the radiological margins of these tumors. And not only that, they are often at conflict with important eloquent areas. And therefore, the dictum or the bottom line of glioma treatment and glioma surgery is to balance the extent of resection with the morbidity or the surgical morbidity that can occur because it has a bearing on the survival. Now, it's important just to understand the interplay between these three factors. We know that extent of resection is important. Reducing extent of resection will reduce the survival. Our aim is to improve survival in gliomas. On the other hand, and this is little less known, is that having increased perioperative morbidity can also reduce survival. And there is a link between a reduced extent of resection and an increased morbidity, which is what we often see, especially in high-grade gliomas, by the syndrome of the wounded glioma, whereby subtotally resected high-grade tumors often have extensive perioperative edema and morbidity. And both of these factors, reduced extent of resection and increased morbidity, can negatively impact the survival. On the other hand, if you try and do an overzealous resection and increase the extent of resection to try and improve survival, you would cause increased morbidity, and that can negatively impact your survival. Therefore, what you want in ideal situation is to have a very high extent of resection and a very low morbidity, because these two together will give you the best possible oncological outcomes. And when we say oncological outcomes, we are not talking just of neurological function in terms of motor, sensory, but as we heard in the very nice talk by Dr. Sushant earlier, is that the neurocognitive function is important, and balancing that impacts the quality of life of the patients. And this can vary from one person to another, and therefore there has to be a personalized treatment when it comes to evaluation and offering therapeutic modalities to patients. The aim of surgery, of course, is to resect everything and to resect beyond what is seen on imaging. This is what we mean by supramarginal resections, because this is known to have a prognostic benefit. And this is why it is included in the most recent RANO-resect criteria. As you can see, class 1 group, which has the best possible survival benefit, is one where everything contrast enhancing is removed, plus almost everything which is non-contrast enhancing, which is T2 flare component, is also removed. However, this does not mean that if you cannot achieve that, there is no prognostic benefit. This is another study which very nicely shows that for every given patient, increasing the extent of resection has an incremental prognostic benefit, which means for any patient, if you have a 70% resection, if you were able to do 80%, it improves the prognosis and the survival in that particular patient. And therefore, the simple answer for how much you need to resect is resect as much as you can, the more the better, but not at the cost of function. And this is where we need to go back and revisit, introspect, and question our existing notions, our existing biases against glioma surgery, where we often come across these discussions amongst neurosurgical groups as well as amongst oncologists. Is there a point in resecting in gliomas? Doesn't matter, prognosis remains the same. And we always try to put up a defense of causing no harm in trying to do a biopsy or a conservative resection in gliomas. But actually, by resecting suboptimally, if you look at all the evidence and the literature which is available, we are doing more disservice to the patient and actually doing more harm to the patient. And therefore, if you are a glioma surgeon, if you are a neurosurgical oncologist, you have to start with the right intent, because unless you do that, your job will not be done. Once you understand and believe in the benefits of resection, of course, as I say, and I say that again safely, then the onus on you is to optimize this resection. And how do you do that? That is done by a combination of correct case selection, the right technique, and if required, use of an appropriate adjunct. And this is, again, as I alluded to in one of my earlier slides, is personalization, customization of surgery for every patient. Now here, let us address the elephant in the room. It's what do you mean by resectability and how much can you resect? Are all gliomas resectable? The answer is no, obviously no. Then how do you define resectability in gliomas? And is there something which is very objective, which different neurosurgeons can probably use the same definition and still come to the same conclusion every time? And more importantly, is resectability something which is inherent, innate to the tumor, which you can't modify, which means is it a dichotomous all or none thing, resectable, not resectable? There are many, many factors which go into determining the resectability, and that is what neurosurgeons use a lot of the times, including the location of the tumor, the size, the volume, its extent, the delineation, the margins on T2, T1, MRI, the enhancing pattern, and the proximity to eloquent structures. Most of the times we use the extent of the tumor and the margins as a guide to assessing and ascertaining the possibility of a resectability. In these cases, especially in high-grade tumors, is it the contrast enhancing margin or is it the T2 flare? These are again questions that we need to answer. And as we know that in half of the cases, this may not be possible to resect. So should we also then extend the resections regardless of this anatomical extent into functional boundaries? And just to show you one of our studies where we've used ultrasound in order to delineate tumor residue and assess factors which influence gross total resection rates. The resectability and delineation were very important, and on multivariate analysis, resectability and eloquent location were the two primary determinants of a gross total resection. So therefore, it does matter whether it looks resectable or no. But I want you to focus on this number here. So we were able to achieve GTR in 70% cases where we thought it was resectable, which means in 30% of those cases, we still could not get a gross total resection. Whereas in those which we had deemed unresectable, we still got a radiological gross total resection in 17%. And this is not just in one example of a study, but other papers that we published, and this is non-enhancing tumors, where again in the unresectable group, we still could get radical resections in a sizable, though not all, a sizable proportion of the patients. So what this means is that resectability, what you determine preoperatively, should ideally lead you to get a gross total resection, but necessarily it does not mean that you will always get a gross total resection. On the other hand, the corollary is that when you think it's unresectable, it does not necessarily mean that you will not get a gross total resection, which means you must not have a bias that this is going to be difficult to resect or unresectable. Yes, you must assess the potential of having a gross total resection, but you should go with a positive mindset, because resectability can differ from one surgeon to another and can differ between MRIs done at different places. Regardless of whether this is looking resectable or non-resectable, if you are going to resect a tumor or a glioma, which is an intraaxial tumor, I think it is imperative that you understand the anatomy. Abida has shown beautifully subcortical anatomy, also the cortical anatomy, which serves as landmarks, both anatomical as well as functional, is extremely important. And also it is important to understand the role of the pia and the glial limitans membrane, which restricts the spread of intraaxial tumors across gyri. That is to say that gliomas spread via white matter tracts or connecting fibers across gyri, but not through or across pial surfaces unless they are breached or in very late stages in high-grade tumors. And this makes it amenable to do extensive subpial resections or gyral resections using this anatomical information. And when we say subpial en bloc resections, we mean not just removing it with a margin, the tumor, but removing the entire tumor-bearing gyrus. Because remember, I told you that the tumor may look to be confined in one particular location, and you may think you've got it all around, but there will be microscopic tumor beyond it. And unless you remove all those microscopic bits up to the pial edge, because there can't be glial cells beyond that, then you're not going to completely eliminate the risk of local recurrence. And this can be extended to multi-gyral resections using the same technique, which is not only much more better and aesthetically pleasing, but also is much more oncologically sound and safer, because if you remain subpial, you're not damaging the sulcal vessels, which are likely to be supplying adjacent eloquent areas. And this technique goes by various names, and it could be circumferential, could be subpial en bloc, or it could be en masse resection. Dr. Goyal himself is a strong proponent of this technique, and I'm sure we're going to hear him later in the course of this webinar. However, and I must again say here that even with good anatomical knowledge, even with the right surgical technique, even with experienced neurosurgeons, assessing the intraoperative extent of resection just by the visual inspection can be sometimes fallacious. And this is one study, many others like this, which showed that when neurosurgeons came out of the surgery with a final assessment of gross total resection and postoperative MRIs were objectively reviewed, in around 70% of the cases, residue was detected, which means that what was planned or thought as the extent of resection and what their actual extent of resection achieved was not concordant. There's a lot of discordance, even with using the right technique and having a good understanding of the knowledge. And this is because of the limitations of visualization, even high magnification, illumination, and because of the very basic nature of gliomas which are infiltrated. And that is why you need something often to enhance that visualization. And there you have many adjuncts, which all of us are familiar with, including navigation, intraoperative imaging. And here I would say strongly that the intraoperative ultrasound is a very useful adjunct, which should be in the armamentarium for all neurosurgeons, especially glioma surgeons. And then you have fluorescence, and I think we will have a talk on this subsequently by Dr. Vivek. However, again, to underline that using all these adjuncts to extend the margins of resection should not come at the cost of function, and therefore functional mapping and monitoring, be it awake or under asleep. And we've seen some very high-level awake mapping, which was shown by Dr. Sushant earlier in this webinar, is very important. Just to give you an idea about the extended resections in our analysis, and we are a team of neurosurgeons, 3 neurosurgeons doing only glioma surgery. And we've been using ultrasound and navigated ultrasound. And this is published from our group. My colleague, Dr. Shetty, is the lead author here. That when we used the intraoperative ultrasound as an adjunct in assessing the extent of resection intraoperatively, I'm sorry if you can't see that slide very well, but when we assess the intermediate ultrasound scan and its impact on the decision that we made and whether it altered the course of surgery, we found that we detected inadvertent residue. It means we thought we had completely resected everything, and the ultrasound picked up a residue, and this happened in almost more than 40% of the cases, leading us to do further extended resections. We checked the diagnostic accuracy and the GTR rate and concordance with MRI, of course, but what I wanted to show you was that the use of the adjunct intraoperatively prompted us to detect a residue which we would have otherwise missed. However, resecting this extra residue and the tumor should not come at the cost of deficits. And here, understanding white matter and its functional importance is of paramount importance. And that's because unlike the gyral level where you have file boundaries which can guide you to the limits of resection, in the white matter, you don't have any such kind of anatomical margins, and you have to rely on functional margins. What we know about white matter is that these are tracks which run crisscrossing across the brain, and they're like highways. They are multi-lane highways, and there is two-way traffic. There is intricate relationship to surrounding tracks, as I said, crisscrossing, and they are full of function. When attempting these radical resections, it's important how we deal with these functional connections. Just to give you an example, this is a diffuse glioma with a lower grade glioma in the basitemporal region. And you can see at the base of the resection, where we want to extend the resection, which is going to be our margin at risk, it is full of these tracks which converge in the temporoparietal zone across the sagittal stratum. And these are all going to be at risk. And like we saw, that can cause a severe neurocognitive decline, even though the patient may not recognize it overtly. And this is the reason why that happens. Of course, we have a lot of tools preoperatively, functional MRI and DTI and other things which tell you how this works and what it is that you're likely to encounter. I would say that they are good guides for your surgery, But presuming eloquence based on this can be fallacious. And again, here there's a very nice study, and this is from Mischberger's group, where they looked at the impact of assigning eloquence based on preoperative imaging versus doing intraoperative mapping. And they found that presumed eloquence can be fallacious and can impact the resection rates and therefore the survival, and thereby it's always recommended that intraoperative you confirm the functionality, because there can be a lot of plasticity. What you think is important and eloquent and the tumor is close to it may actually have got reorganized, and you would be able to resect much more, and vice versa. And how you do this is by both awake and asleep methods, using neurophysiological techniques, as well as awake mapping and a range of customized tests which are selected based on the patient's preoperative functional performance. What intraoperative mapping does, and this is a huge meta-analysis published by multiple large groups which have been doing this for years together, showed that using intraoperative mapping, you might have temporary increase in postoperative deficits, but a definite reduction in late severe neurological morbidity. And it is also not, it does not happen at the cost of lower resection rates, which means you get high resection rates, even in eloquent regions, with lower long-term morbidity. And this is the value of having intraoperative functional mapping and monitoring. Again, a distinction between the philosophies used for high-grade versus low-grade gliomas. In low-grade gliomas, you can exploit the plasticity and the time that is available for this plasticity to develop in order to achieve supraradical and sometimes suprafunctional resections. Whereas in high-grade gliomas, it's always best to stay within functional limits, because there is an important aspect and an important component of the adjuvant therapy, which has to be given timely in case patients develop perioperative morbidity. This may not happen, and then you defeat the entire oncological benefits of a radical surgery. So a combination of various techniques and adjuncts is available, and depending on your aim, based on your assessment of the patient and the resectability and its location, you could use them. It's not a hard and fast rule, and it's something which each one develops with their own practice and experience. Essentially, what we are doing in glioma surgery, like most neurosurgery, is to avoid error. The error can be an error of commission, like causing morbidity, or an error of omission, that means missing a residue. And this is like this. It's the Swiss cheese model of error avoidance, where you have multiple layers and checkpoints, where you look at any factors which could lead to latent failures. And if you address them, then you prevent converting them into an active failure or an error. And these checkpoints are at multiple steps. And in case of glioma surgery, you have starting with case selection, then planning, using the right technique, and finally the appropriate adjunct helps you minimize the chance of these latent errors becoming actual errors and manifesting as adverse outcomes. And that's why I again say that it's a combination of technique, adjunct, and a basic knowledge and understanding which helps you optimize the treatment. And these are important competencies that a neurosurgeon must have if he's dealing with these complex tumors. And with that, I would like to end my talk and leave you with this. And happy to share that we are conducting this workshop, competency development, and anyone interested is more than free to register and attend. Thank you very much.
Thank you, my dear Ali. I'm very happy and very proud to hear your presentation. You have indeed become a leader of the field, at least in the country, if not all over the world. You have now developed, your talk was a little more philosophical than I have ever heard from you before. And this philosophy, as you know, and as we all know, is very important and critical when we do any kind of neurosurgery in general, and glioma surgery in particular, and high-grade gliomas in more particular, because the risk and the stakes are quite high, and any kind of deficit in these kind of tumors can be quite dangerous and devastating. So what you said and what you propagate is indeed very rational and very important. One thing I would like to ask you, if you mentioned about gliomas extending along white fibers and highways of white fibers. In my information and my literature search, we were the first one to describe this concept that gliomas arise from a white fiber tract and grow along the white fiber tract and displace the adjoining white fiber tract. Do you have some any additional literature before our presentation on this subject, that this is the course of traverse of gliomas? I will be very unhappy if you say yes, but if you say yes, then I will be able to learn from you. Ali.
So I think, sir, of course, I've not in the recent literature, I've not come across, but if I remember correctly, in Yasargil's book, they have described gliomas as involving along the neurovascular and along the white matter tracts. And they have described it crossing from one gyri to the other under the U fibers without breaching the pia. But your concept of gliomas following name tracks, I haven't come across.
The other thing in Yasargil's paper, as you mentioned, you see what in Yasargil paper the mention was that along the vascular territory, like an infarct is a wedge-shaped infarct because of the artery going like that, in a wedge. Similarly, what Yasargil had mentioned essentially that gliomas grow towards the ventricle. In our concept, what we say is that there are vertical projection fibers and various kinds of corpus callosal fibers which prevent the flow of gliomas towards the ventricle. And periventricular gliomas are different and subcortical gliomas are different. And this different, the white fibers make the difference. So this is the concept which is in variation from what Yasargil had described. I think, this is very important and critical to understand this. When you talk of confined nature of gliomas, you see, gliomas are a cancerous tumor. You cannot have a tumor like glioma which is confined. Obviously, it is surgically confined. You can get a plane of dissection surgically, but the cells go here and there and there and here. When I say adjoining white fibers are displaced, obviously, the function is affected by displacement and distortion, but also there is some kind of destruction of the adjoining white fibers. I think understanding gliomas along the white fiber tract, in my view, has quite a revolutionary impact on the subject. I want your brief comment, my dear Ali, on this.
Also, I agree. I think the final word has not been said still in the glioma. There is a lot of literature which describes the subventricular zone as the origin of gliomas and the radial glial fibers as the tracks along which these gliomas, which were subventricular zones, germinal cell origin, then move on and spread to the cortical surface. However, it's also known that they follow the white matter tracks, and as you rightly said, they go along named tracks. But when it becomes high grade, the high grade gliomas, there is a possibility of them even destroying and damaging and breaking outside the confines of these white matter tracks, which sometimes can be manifested by multifocality and multicentricity. So there is more to it than this. And maybe in the next few years, you will have found the answer to that also, I'm sure.
Another thing, Ali, we are just having a kind of discussion. In this article of mine, we have also said that high-grade gliomas are high-grade by virtue of their multiplication pattern and characteristics rather than extension pattern. So high-grade gliomas are also within a confined kind of territories, basically surgically, not, histologically you cannot have ever, but you can design a plane of dissection around the high-grade gliomas also. This is what the feeling is. Now, in this respect, I would ask you one last question. about the use of ALA in your experience, how far you have gone in this and how much you think it is good in all kinds of gliomas, whether it is low grade, high grade. Just give a brief comment on this, Ali, because I think your experience will be informative to all those who are hearing this webinar.
Yes, sir. ALA, you mean the fluorescence, you said, right?
Yes.
Yeah, no. So it is, we've used it in high-grade gliomas very selectively, only in enhancing tumors, and it is extremely useful. But it's useful because we see a distinct difference when you switch from the white light to the fluorescence, and you can see fluorescence, and we've even done a study in which we've sent those biopsies, and they are tumor, which you have missed without the fluorescence. What is important is that if you're going to use fluorescence, and we are careful when we select about it, is that you have to be ready to push the resection boundaries of that fluorescence till you encounter functional margins. And therefore, functional mapping then becomes very important if you're going to try and do that extensive resections. So I would say that, yes, it's very useful, high-grade gliomas. It helps extend those resections, but it should always be done carefully in close to functional, eloquent subcortical matter. So you're muted, sir.
Another brief comment I wish that you make is on what Dufault says about functional mapping and depending, and the entire surgery is based on functional mapping. And he says that it is not required, this is not required, so microscope is not required. That means he's a leader and he's our teacher, and there's no question about his absolute contributions on the subject. But I wish that you make a comment on what you think about functional mapping and glioma surgery.
So I think for low-grade gliomas, which is where he propagates that concept, because that's where he applies it, I think there is possibly a theoretical basis for doing that. In practice, we find it very difficult to implement that because the extent of functional mapping and monitoring that you need to do for that is quite vast. And I would say that in that regards, he's a master and probably he's able to achieve those. I would say just like how you are able to do your glioma surgery without the use of many adjuncts and still achieve the endpoints and the outcomes which others cannot. So I think it's the principle that we all need to understand and imbibe, and then what we put in practice depends on what best we are able to get out of and how the outcomes we are able to get out of that.
Thank you, Ali. All in all, that was a very beautiful presentation. And I can only say that I wish you all the best in your endeavor and take the flag further higher. And the way you are going is indeed makes me very proud and very happy. Thank you, my dear Ali.
Thank you, sir. Thank you very much.
So let's move on. I'd like to now invite Dr. Vivek Tandon, who is additional professor at the All India Institute of Medical Sciences in Delhi. He's going to be talking about indigenous 5 ALA and light source to guide glioma resection. Vivek.
Can you hear me, Abida?
Yeah, Vivek, I can hear you. I can see your screen, but your presentation not yet.
Yeah. Thank you, Professor Atul and Abida, for inviting me. And can you see my screen now?
Yes.
Yeah, so I shall be presenting on utilization of 5-ALA dye that we are now manufacturing, and we are able to visualize it using the innovative visualization tool that we have developed in conjunction with the grant from ICMR and with the Indian Institute of Technology in Delhi. And I will briefly show you that, and I will be brief so that we can finish the presentation on time. So as like Professor Ali had just mentioned, the fact that glioma is one thing that mankind has not been able to conquer. And we all realize, I mean, it's a disease where high-grade gliomas, they have a very high mortality and morbidity involved. We understand, all of us understand that only thing that we can change is probably the extent of resection. Because we cannot change the age of the patient, we cannot change the genetics, we cannot change the kind of tumor behavior that is there. So how do we do that? There are multiple ways of doing it. And we have been utilizing practically everything that has been there on planet Earth, at least at All India Institute of Medical Sciences. We had intraoperative MRI. We had all kind of navigation gadgets. I learned from Dr. Ali, and we bought the best quality ultrasound that Dr. Ali has. But we realized that when you are operating these tumors, it's at times, whatever gadget that you're using, it becomes difficult to differentiate between the normal and the abnormal tissue. Dr. Atul just now said that, yes, in high-grade gliomas, you can find a plane. But despite having a plane, still there is a chance that there is some proliferation of the tumor tissue beyond the planes, and you will not be able to differentiate it with the naked eye. At times, when the eloquent structures are nearby, it becomes even more difficult to do that. How do you identify the abnormal tissue? Yes, if you have intraoperative MRI, it helps you during surgery, but it's a tremendously expensive gadget to have with a lot of problems associated with it, because if you have it, the duration of surgery increases many folds, and people like Professor Goel will never like to use it because of simple reason that they have operated thousands of gliomas. And with experience, you are able to differentiate between what is tumor and what is not tumor to a great extent. But still, there will be 5% cases where fluorescence will make a difference. For even people as experienced as Professor Goel, I'm telling
How
you.
you doing?
So,
Yeah, who's
somebody,
this?
I think somebody is speaking. Maybe you can
Jimmy.
mute.
Yeah, John.
Billy, how you doing?
John.
Good to hear from you. No, I'm doing a conference from India.
John, your audio is on. Oh, okay.
So one of the dyes that is there is 5-ALA, and the beauty of this dye is that it gets accumulated in the tumor tissue. And it's a protoporphyrin 9, which is there when you subject this dye to a blue light, which is of around 400 nanometers. It absorbs the blue light and emits it in the form of a pink color. And that's how you are able to differentiate the tumor from the normal tissue, which is there, which is not going to take up the dye. So we realized that this dye is available in the market. I saw it with Dr. Ali, Dr. Sable, Marian Rapp. These people taught me how to use it. But the basic problem was that the cost of the dye was very humongous. It was around 1.5 to 1.75 lakhs per vial that used to cost to our patients. Then you had to procure a license in our place. And for every individual patient, if you want to purchase a license, it's a terrible thing because ours is a very busy setting where patients are waiting for a very, very long period of time. The waiting list for glioma surgery can be between 3 months to maybe a year also for a low-grade glioma, or maybe 2 years also. So you can't have a patient in the ward who is waiting to get a license and then you operate. We admit the patient and we operate the patient. That's how the glioma surgery is done at our center. The cost had to be reduced. Then the other problem that we realized was that the visualization through a microscope again is a costly, adventurous thing because the costing from Carl Zeiss is around $40,000. Similarly, by Leica and Mitaka, it's expensive. So what do? We realize that the dye can be prepared in our own setting. And when you are trying to search for people, I went around the whole country looking for a person who can manufacture the dye for me, only to realize at a later date that in the next door of my hospital, there is a Rajendra Prasad Eye Center in AIMS, and they have a very beautiful pharmacology lab. And in this lab, there is a doctor named Vel Pandian, very, very experienced, very energetic person who said that he will be able to do it. And this is his lab, very state-of-the-art facility that we have, where he started manufacturing the dye for us. That helped us reduce the cost tremendously. And we could give this oral formulation to the patients. This lab manufactures many other drugs, not only for patients of ophthalmology, but for many patients of AIMS also. But we had no idea that it existed in the next door to us. Fortunately, we found that. And now we procure the dye from this lab and we administer it to the patients as part of a study by the ICMR. The only precaution that we take is that we keep the patient in dark surroundings and we do not expose the patients to direct sunlight. But we realize that the kind of ambient light that we have, even these precautions are not required according to me. I have never seen phototoxicity in last 30 patients that we have operated. We utilize dim settings in the operation theater as well, as you can see here. But again, we have never seen phototoxicity till now in our setting. The light source was a problem, and we developed it with the help of IIT Delhi. The picture that you just saw was of Professor D.S. Mehta. He's again a very experienced person from the field of optics. The first generation device that we manufactured was an optic fiber, and we could use spectroscopic analysis also with this. But the problem that we realized was the area that could be visualized was very small. It was mainly for maybe oral cancers that these people had utilized this kind of a fiber optic device, but it wasn't useful for us. So we went on and requested them, provided them with some ideas, and sat with the engineers and developed another device, which was more like a torch to us, but only to realize that this torch kind of a device that we had manufactured, it had its own share of problems because somebody had to hold this torch. And then there was an issue with the sterilization. The wire was not very long. It is only when you collaborate with engineers, then you realize how difficult it is to manufacture something at times, because what you communicate to them is interpreted by them in a very different manner. And sometimes these devices may not be ergonomic. So this is the third generation device that we had manufactured. It's kind of an endoscopic kind of a thing. I'll just go back and show you. So the third generation device is like an endoscope kind of a thing that we have manufactured. It has got lights, and the illuminance is also very good in this third generation device. But again, the device was very bulky, and in the maybe next week onwards, we will be utilizing a fourth generation device, which is output of this one that you are seeing here in the picture. And I do not have pictures because I cannot show them to you guys right now. We have to meet again this week and finalize the design, and maybe by next week we will be able to use that. So I'm just showing you a few cases here, Abida, that we have operated, like the tumor that we just now Dr. Ali showed. So this is one case where patient had been operated earlier. He himself is a neurosurgeon, and it's a recurrent case. And why I'm showing you this is that the visualization, even in recurrent tumors, is very good. You see here, you will be able to visualize the bed, and you will be able to see that this part is tumorous in origin, and you can again excise it completely. But we realize that glioma, whatever said and done, they end up coming back. So this is the extent of resection post-operatively. Day 0, the protocol is to get the MRI on day 0 itself. We try getting MRI of the patient on the day of surgery when the surgery is over. So this is another patient, again, a recurrent case of left frontal glioma, who was operated earlier by me, and she came back with the tumor, the big tumor. And here, what Dr. Ali was telling you was that even if you see margins, at times you cannot resect them. And if you see here, the tumor is reaching up to the motor strip. The tracts are here, which are very near to the tumor. And while during surgery, when we stimulated this patient, we realized that you see here where I'm stimulating with my suction, we realized that the motor strip and the motor tracts are very nearby. Despite seeing the illumination, you see the margins and the whole cavity is getting illuminated, but the tracts are very nearby. The only thing that we could have done for this patient was remove the tumor, which was in the non-eloquent part. So this comes with age, this comes with judgment, that not everything that you are seeing, which is tumorous in origin, you cannot go ahead and excise it. So again, the same thing, we kept on excising till we found the negative margins anteriorly. We left the tumor at the posterior border, and the patient did fine in the post-operative period. And this is how we use it. We were able to even send the images to iPad and record it. But unfortunately, the quality of cameras till now that we have utilized is not very great. We are working on the quality of cameras with the IT people, and maybe in times to come, they will be able to sort it out, and we will have better pictures from the camera. So right now, what I can tell you is that we have operated around 30 patients till now, and these patients are doing pretty well. We have been able to excise tumors as much as we could, and the results are good in nature. I won't call them fantastic, because when you follow up patients of high-grade glioma, you will realize many of them will start coming back after some time. We started this study in the month of March, and it's January now. So in around 9 months, 10 months, we have operated 30, and I can say that we have seen at least 4 to 5 patients who are coming back with recurrences which cannot be operated upon. But if we look at the control arm, where the other group of patients is, I can say that there is a marked difference. I will not be able to comment today what is the statistical significance of that, because we can only analyze the data once the study is completed. But there is a remarkable difference between the two arms. And at the end of surgery, we again image all these patients. And as you can see here, most of the patients are doing fine. And here I'm just trying to show you that the cases that we have operated in our setting, they are usually big cases and difficult cases. But you can see the second picture, which is there in the second line. This is the post-operative image, and you can yourself make out that the extent of resection is really good. The margins where you are seeing the enhancement, it is there because in the post-operative period, the dye leaks out, and when the dye leaks out, it appears as if there is some amount of residual tumor. You have to compare it with the FLAIR and T2 GRE sequence to really understand. So this patient again is a doctor, and she was operated earlier for insular glioma. She came back with again huge recurrence, and she's doing fine. She was operated again. And this is how we calculate the extent of resection. These are the I-plan images that have been utilized. And we have operated few patients using fluorescence, many patients using 5-ALA, and there are patients in the control arm. And we realize that the extent of resection in the arm where 5-ALA has been utilized is really good. This data is for 10 to 15 patients when we were operating initially. So we need to again go back and analyze the data once the study is completed. We have promised around 30 patients to the ICMR, and we should be able to deliver those within a month or two's time. And you can see that there were many apprehensions because this dye was being manufactured at our facility. We thought that maybe LFT will get deranged. Patients may develop phototoxicity. All these things are described in books. But we realized that in most of the patients, the LFT values were within the normal limits. And in none of the patients we found that they had phototoxicity. So we found that this dye is very safe. We are going to analyze the plasma serum samples as well for these patients, which are collected on day 1 and day 3. And the T-half for this dye is very good. Within 3 to 4 hours, the half of the dye is washed off. And by the next day, I personally believe the whole dye is out of the body. So I find it to be a very safe dye. Yes, we realize that the device is not very ergonomic at present, and we are working on it. We will be having 4th generation device, as I've already told you, by next week. And I'm sure that if the device is good, we will be able to provide it on commercial basis with a tie-up from few companies. And let's see how it goes. And the next step obviously is that we can end up utilizing the fiber optic probes for Raman spectroscopy or optical coherence tomography. We are working on that, and maybe in next few months, we may be able to have a project on that also. And building the AI interface, we have a very good center in dental department, which is working on AI technology. And we are going to have a tie-up with them and see how it goes there. And with this, I would like to thank Dr. Abida and Dr. Atul and all the people who are listening to this talk. And I must also thank my collaborators, which are there in IIT Delhi, Professor Dilip Singh Mehta, the ICMR, which has been very gracious enough not only to provide the money, but all the support, whatever we had asked for has been provided, and the grant has been extended for this year also. We are very thankful to them. Thank you.
Thank you, Vivek, for that lecture and that information about your work and about the thing that you are developing with IIT in Delhi. And I'm sure you will get all the success. I wish you all the best, and I know you are doing fantastic work. I know what work is going on in All India Institute. So my best wishes to you, to your team, and to your other colleagues in All India Institute. Vivek,
Thank you, sir.
congratulations and best wishes.
Thank you, sir. Thank you.
Thank you, Vivek. There is one question in Q&A. I think you can just answer it. Let's. Yeah, you can just type the answer. I think it's quite a long question. I think you've answered most of it, but just look at it again.
So is the dye chemically different to 5LA? No, it is not different. Have you been able to compare it against 5LA? So the dye in itself is 5LA. So there is nothing to be compared of. If you want this to be compared with fluorescein, then yes, it is more sensitive and it is more specific, highly specific, I should rather say. In recurrent cases, is all the dye positive tissue tumor or does histology shows gliosis? Yeah, the dye will only be picked up by the highly dividing cells. So if the dye is there, it is likely to be a mitotic cell rather than a gliotic tissue. So I think I've answered all the questions, Dabida, here.
Thank you, Vivek. So we move on. I would like to now. Thank you, Vivek. I'd like to now invite Dr. Dilip Panikkar, who's a senior and experienced neurosurgeon. He is working at the Aster Medicity, Cochin, and he's been talking a lot about neuro-oncology from the beginning. Let's hear what Professor Panikkar has to say. Sir, you're muted.
Yeah, sorry. I think a bit of. Okay, can you hear me now?
Yes.
Okay, thank you. Thank you, Abida and Professor Goel for inviting me and providing this and putting these set of talks together. Very informative and very important talks, very important topic. And I'm happy to be participating in this. So a lot has been said by various speakers about different techniques and the philosophy of glioma surgery, the need to be aggressive and maintain a resection, and something about to talk about the various techniques that are used to maximize resection and minimize the morbidity, and thus achieve a excellent outcome when we talk of the progression-free survival and the overall survival of these tumors. So my talk here will essentially focus on this subset of functional mapping. I will not go into the techniques of surgery, but I will just talk about the importance and the technique of mapping and what we do at our center. The conundrum of gliomas has always been a puzzle. It's a wide spectrum of tumors ranging from the extremely low grade to the exceedingly malignant and aggressive tumors. And for all of them, the primary treatment is surgical excision. And as has been repeatedly demonstrated by various speakers and in literature, the extent of resection correlates strongly with survival outcomes. The flip side is, much as we would like to resect all these tumors, a large number of them are situated in or are very close to areas that subserve important and critical functions in the brain. And attempting to resect these, attempting to radically resect these might result in unacceptable deficits and seriously compromise the quality of life and even the survival of these patients. So there is this conflict between pursuing maximal resection and maintaining function and the quality of life, which has been referred to in various terms, including the term oncofunctional balance, which is very important. And this is a juggling act that every surgeon who operates or treats gliomas has to maintain. So to aid this, to facilitate this, and to tip the balance towards maximizing the resection and minimizing the deficits, identification of areas that subserve these functions are important by various means. And once you can identify them, you can protect them. So the current standards include many, but the gold standard now is essentially cortical. And so it's stimulation mapping, both at the cortical and at the subcortical level. And there are differences with the patient being asleep or awake. We will talk about that. And this whole concept of this idea of what is called eloquence, which the term eloquence referred to the assumed presence of functional tissue, which I will talk about very briefly in the next few slides. So as I said, the presumed the term eloquence, what is eloquent? What is the presence of functional tissue? Now, these can be determined even preoperatively. There are many ways to do it. One of the earliest ways was by using Brodmann's anatomical areas, which tried to define these anatomical areas. And that was a time when it was thought that functions are very tightly linked or very tightly localized to certain areas in the brain. This concept, as we now know, is no longer valid. Imaging and various imaging modalities help us to identify or to predict where functional areas might be. The magnetic resonance imaging, which is a standard for all these tumors, gives us a huge amount of information, and there are very specific sequences in the MRI that can show us the white matter tracts, can show us functional areas, and using newer techniques that are now becoming available using computational techniques, the processed information from the resting state fMRI, one can even predict or look up for or identify networks within the brain. To confirm this or to add to this information, one also has the ability to use techniques like transcranial magnetic stimulation, and if available, the MEG, magnetoencephalography, which can further help delineate function. However, these are not often available and are very, very restricted and available only at a few centers. The earliest one of the early attempts to identify or to define eloquence or functional areas and correlate with the prediction of the overall survival and the PFS was Chan system, which the UCSF which was mainly for low-grade gliomas, where they use these 4 points, and one of the points was eloquent involvement. In their paper, the definition of eloquent areas of the brain were confined to language areas, motor sensory cortex and tracts, visual and auditory cortex and tract. There have been many definitions of eloquent areas over time, and as you can see, there are various ways by which eloquent areas are graded, and these are all used to predict resectability or to try to define preoperatively what is resectable and what is not. There are extensive papers that define or that lay out what has been defined as eloquence. So the definition of eloquence itself is not very clearly understood or not accepted by everybody. So the intraoperative determination of function, especially by using, as I said, the stimulation mapping, both at the cortex and in the subcortical region, is the gold standard. This can be done with the patient asleep or awake. With the patient asleep, only motor stimulation and motor stimulation mapping is possible. With the patient awake, many other functions can also be mapped, including and especially including language and other cognitive functions. So when we do a direct electrical stimulation, we look for responses, either positive responses where there's a brain function that is evoked by stimulation, for example, an evoked movement. There are negative responses where a brain function that is suppressed by stimulation. And this we typically see when we see speech arrest or errors in naming of object recognition or in response to questions. There are also false responses, false positive and false negative responses, which have to be identified. For example, a speech arrest caused by a positive motor response where the muscles of articulation are stimulated. And this can be interpreted as a negative response when we talk of a speech arrest. So identification of functional areas using IONM, one of the simplest and most widely prevalent ways is by using SSEP, phase reversal, to identify the central sulcus, and like I said, stimulation mapping, where one uses either bipolar or monopolar stimulation to stimulate the cortex and to identify the motor tracts. The most conventional tests that are done, or the paradigms that are used, especially with awake surgeries, are language assessment, includes number counting, visual object naming, and so on and so forth, and motor. And these are probably the most common kinds of functional assessments that are done for tumors. These are some examples of how a functional assessment is done intraoperatively. As you can see, the entire setup is geared to facilitating this kind of an observation and assessment. And the use of transparent drapes permits a direct line of sight and communication between the assessor and the surgeon, so that any information, any changes are immediately conveyed back to the surgeon. So I will skip this here. So the whole process starts with a comprehensive assessment for all patients to identify whether they are amenable to awake surgery or not. And one thing that is important to understand, that a negative stimulation response is often considered a lack of and evidence for lack of function, but this is not always true. So many people use a negative mapping as a go-ahead or as a green signal to go ahead and to resect. But this often can miss certain functional areas and result in deficits. So what we often do is a real-time continuous testing through the entire procedure. And this involves a repetitive series of tests, but these tests keep switching so that your patient doesn't get practiced in when the same test is administered again and again and again. So these are some of the tests that we use, and these are defined and these are determined based upon the areas involved or the cortical areas, the tracts that are involved. For certain specific areas like the supplementary motor area, we use certain other tests like the dual tasks, where there's a combination of a motor and a verbal task, or a bimanual task where the patient is asked to alternate movements. And these sometimes are more sensitive in picking up very fine changes or alterations in function. This is important, especially when you're checking dexterity, when operating in and around the primary motor area or around the supplementary motor area. So as I said, the changing concept of eloquence from that very simplified definition of motor, sensory, auditory, visual, and so on and so forth, where every part of the hemisphere is known to support function, does support function, and these are important for maintaining the quality of life. And many of these include, for example, the executive functions, the visuospatial, and the social cognition. So we have been, over the last 10 years, we have over 700 gliomas that we have operated, and more than 300 of these were operated away. We at our center prefer to operate all gliomas awake, whether they are in the so-called dominant hemisphere or in the non-dominant hemisphere. So all our patients go through this very extensive mapping through the entire procedure. And as you can see, we have evolved over time. In the initial years, our assessment was very basic with just counting in gross motor movements and then over the years, we progressively introduced more tests. And right now, this is the paradigm that we currently follow, where we use a plethora of tasks, not only for the sensory motor and visual and the language, but also for higher order cognition as well. All patients have a detailed preoperative discussion with the neuropsychologists, and these tracts are mapped out around the tumor, and so that the sequence of assessment, the tests that are to be administered are defined and agreed upon before the patient is taken in for the surgery. So the sequence of assessments in surgery generally starts with the basic cognitive functions, the language, motor, and the non-language and the non-motor assessments. Then the next set goes into the adapted assessments based upon the domains involved or the deficits identified based upon preoperative evaluation. And then these are interspersed with the tract-based assessments based upon the proximity of the lesion, and this is determined by in the pre-surgical discussion where these tests are identified and determined. So these disturbances of function in the higher order functions, the disturbances in the higher order functions can severely affect the quality of life. And these are important for maintaining the activities of daily living. And many of these, for example, the visuospatial attention, orientation, working memory, and the coordination, proprioception, these are some things that can be assessed now. Now, these functions reside not in specific cortical areas or subcortical tracts, but in networks within the brain. As you can see here, there are a whole lot of networks which can now be identified with processing, with processing of MRI and diffusion tensor imaging sequences. And these networks can be identified and mapped through the surgery. So to map some of these higher order cognition, we use some tests like clock drawing, line bisection, face recognition, emotions, what we call reading the mind in the eye tests. Now, these, from a psychological perspective, they are standard tests, but these can be adapted to use in the operation theater during surgery, and these can assess the cognitive functions. And gestures, especially for frontal aslan, for sequential motor planning, can also be done. These are all variations of the standard motor assessment and assessed dexterity, among other things. Now, this is how the entire mapping is done and recorded and summarized at the end of the surgery. A few examples here. A 60-plus-year-old gentleman with a left hemisphere lesion, perisylvian lesion. He presented with seizures, no deficits, no identifiable neurological deficits, but he had abnormalities that were detected on cognitive assessment. And this based upon, and this with a detailed intraoperative mapping, we could resect it near totally. However, as you can see here, during resection, there were these deficits identified at the posterior edge of the tumor, and that is what led us to stop the surgery at that point. So another example, a young lady, again with multiple seizures, who had presented with abnormalities of speech and syntax, and had cognitive deficits on assessment. Again, this could be resected almost completely, and at the posterior edge of the tumor, there was facial twitches identified. Apart from that, she came through the procedure without any deficits, and this tumor could be resected completely. Another young man who had this large tumor that was involving the supplementary motor area that was resected. He went on to develop a delayed drop, a delayed deficit after the resection, and this is very typical of a SMA syndrome. This gradually improved over time, and he received adjuvant treatment, and 6 years later, he remains disease-free. He took time to recover. Now, this is very typical of an SMA syndrome. He developed the deficit, which recovered, but it took time. It took him almost a year and a half before he was able to get back to work. And he still continues to have emotional issues. Now, this is a young lady, a dentist, a young mother who had this huge tumor and was and had deficits on detailed assessment. She, however, was very particular that she did not want any deficit, even at the cost of leaving behind tumor. She was very particular. And this was extensively mapped. All the tracts around could be found. And we found the frontal aslan tract that was skirting the posterior margin of the tumor. So she underwent surgery. And right at the posterior border, where we expected the aslan, she developed speech hesitancy and arrest, and the surgery was stopped at that point of time. It's right here at the posterior edge of the tumor cavity. And as expected, she had this thin sliver of tumor at the posterior edge of the cavity, and but she remained absolutely intact. So the histopathology was a grade 2 astrocytoma with a good molecular profile, and she is being followed up without any adjuvant therapy as of now. So this is where we also have to understand the surgeon often does not decide for the patient, and the surgeon cannot decide for the patient. This has to be a discussion between the patient and the surgeon, so as to what to expect. Like the last lady, there are people who may be very particular that functions have to be preserved at any cost. Whereas on the other side, there may be people who might say that I do not want any tumor I'm willing to accept it, but please go ahead and resect the tumor. And this discussion is very, very important to have before embarking on the surgical procedure. Something that is important is early rehabilitation, and techniques like stage surgery based on neuroplasticity help to push the margins of resection while maintaining a good functional status. So to conclude, it's in this day and age, it is probably appropriate that every part of the brain is considered eloquent and does subserve function. People's demands and people's patients are aware, and they are often very demanding as to what they expect from the surgery. And this is very, very important. So functional mapping has a very important role in not only in maintaining the quality of life, but helping the surgeon to push the boundaries of resection in a safe way while protecting the patient in all possible ways. Thank you very much.
Thank you, Dilip, for that very, what should I say? What should I say, Dilip? Fantastic presentation based on lot of work, lot of experience, lot of thought process, hard
Dr.
work.
Goyal, I think you're muted.
No,
Now you can hear me?
he's not muted. We can hear him.
Hear you, sir.
You can hear him.
Yeah. So, Dilip, that was a wonderful presentation, and I
Thank you.
believe it was based on very long-standing, high-quality work, very profound, deep insight on the subject, and no question about it, with very big experience now that you are having, and in a setup which is not a academic center, but still a high-quality academic work that you are able to produce. I can only congratulate you, and let's hear more from you in the coming future, Dilip. Thank you very much for that presentation.
Thank you, Dr. Goyal.
Thank you, sir. We'll move on to the next presentation. I would like to invite Dr. Anand Balasubramanian from his talk on optimizing adjuncts in glioma surgery for maximizing resection safely. Dr. Anand is the head of neurosurgery at the Institute of Brain and Spine at Amrita, Faridabad. Dr. Anand, you can share your screen.
Thank you, Dr. Goyal, for taking a great interest in glioma, and it requires a personnel like you to drive a topic like this, which has been very nihilistic in approach over the years. And thanks for showcasing India in this forum. And thanks to both John and Abida for this opportunity. I'll quickly go through the topic. As we have heard from all the speakers so far, I think everything is covered. I'm not going to say anything new, except that I'm going to try to optimize the adjuncts. So what I've seen is most people listen to these kind of talks and then see people like Ali, Dr. Panikar, and people in names like Dr. Vivek, or sometimes me when I talk about intraop MRI and stuff, and then they think glioma is out of reach for normal surgeons. It's not true. There has to be a certain kind of method behind what we practice, and it's not that every case requires all the adjuncts. So I'm just going to try and see where I can optimize. Just the introduction part showing that the margins of tumor when we talk about resection, total resection had not been very clear, but now we are very clear. The T2 flare margins in a low-grade glioma or the contrast enhancing margins in a high-grade with some part of T2. However, literature is still not clear about gross total, subtotal, so one has to be careful, and extent of resection remains prognostic. We have the entire armamentarium of adjuncts from awake craniotomy, intraoperative mapping, navigation, DTI, ultrasound, intraop, MRI, and then the fluorescence, which you have already heard. So I'll just show you three different types. Here you can see a very well demarcated lesion, which can be excised, which Dr. Goel also keeps talking about nowadays of en masse resection. And then you have these deep-seated lesions, which some enhancement there, which is causing total tumor with necrosis, but well-defined margin. And then you have large necrotic tumor with a lot of perilesional edema T2 component, which may require more resection. So these are three different types of phenotypes. They could be gliomas, which are malignant or benign. So if you actually see the low-grade gliomas, this is the total resection, and this is the area of flare hyperintensity that we normally see on the MRI. Now, Dr. Ali also talked about supramarginal resection. So in these tumors, we are resecting normal brain surrounding the tumor up to a margin, which Sushant and Dr. Panikkar had stressed about are having eloquent fibers running all around. So the margins of this resection is not just the margin of tumor, but it is the starting of eloquent brain. That's what Dufoff is saying, and that is what supramarginal resection is. So if you are concentrating that, then the adjuncts you use are different. Whereas in a malignant tumor, where the total resection is defined as the central necrosis and the contrast enhancing rim, which is what is white on a scan, and then the T2 flare area is still not well defined how much to resect, except that we know the more we resect that, the better is it for the patient. And here, most of the adjuncts don't work well. We have to understand even intraop stimulation, whether it is DTI, whether it's navigation, they are all going to be limited in this margin. But in the contrast enhancing margin, probably fluorescence works very well. And this would be a very good guide in these kind of tumors. So whether it's low or high, we see that we use a lot of intraoperative mapping nowadays on the surface and in the depth of the lesion. And we have so many of these adjuncts, starting from fluorescence, Raman spectroscopy, on vivo microscope is now commercially available, not yet in India, but abroad. And then we have navigation, we have intraoperative ultrasound, and we have intraop MR. So the anatomical delineation, we have the microscope, the MRI, the ultrasound, navigation, and fluorescence. For functional mapping, we have intraop electrophysiology with DTI and functional MRI with navigation and even TMS. Now, this was the eloquent brain when we studied, and now there are too many eloquent structures in the brain, which Dr. Abida has beautifully demonstrated with all her dissection techniques. Now, what do we do? I'm just going to show you some examples. So this is eloquent area lesion. So when you operate on eloquent area lesion, obviously you need to do under awake mapping if possible. I'll try to see if the video plays quickly. I'll quickly show that we can combine a lot of these techniques, not just doing mapping, we can even do with navigation control, and even in an awake situation, you can do motor evoke potentials or stimulation with lower current. So it is possible to combine, like Dr. Panikkar showed beautifully, a lot of various paradigms are available nowadays for studying the deep white matter fibers. So they may be the margins of the tumor resection, or as here you can see, sometimes the functional MRI shows that the speech area is displaced down. So it becomes very essential for you to map as you are resecting with deep cortical stimulation. With intraop imaging will be of more use in these cases. If the eloquent cortex is little away from the tumor, then you just need to know what is the direction you need to be more careful. You may not go right up to the margin to elicit a stimulus from the surrounding eloquent cortex. So in which case, mapping with just the DTI and navigation may be enough. Like in insular tumor, if you're in the anterior insula and you are not operating in the deep white matter, you can quickly turn on the navigation in the microscope. And as you can see here, you can have the temporal part, the insular part mapped out and stay within the area of the focus, where the margins keep changing as per the depth of your focus, and you can resect safely within the margins of the tumor. Now, if the DTI and fiber tracking works without a lot of edema and disruption, that is very good. And we also know that intraoperatively, we can image these if you have a high field MRI, and you can see that they do change position during the surgery, so that you get directional information, even though you are not going to be very close to them to elicit a response. If you are just directionally know which way the corticospinal tract is, you're going to be more careful in that particular direction. So DTI guided or intraop monitoring guided, depending upon whether you are closer to the lesion or far away from the lesion, would be suitable. Now, in supplementary area where you want to avoid a SMA syndrome, one may want to do an awake, but it may be at the cost of leaving behind tumor, knowing very well that these tumors, these patients tend to improve very well, except when there is language dysfunction, or if there is bimanual task importance of preservation, we can still do them safely in a asleep situation or a awake paradigm, and then resect the tumor of SMA completely and still have a recovery from the deficit if they land up with a deficit. So the risk of landing up with lesser resection because of a deficit on table when you are doing awake should be kept in mind, even though one should not be too aggressive and land up giving the patient a permanent deficit. Towards that, the next modality is the yellow fluorescence. We see here deep-seated thin enhancing margin can be resected completely with fluorescent guided resection. We use yellow fluorescence a lot. As Dr. Vivek said, the cost of this ALA is quite prohibitive as of now. Thanks to him, with the local Make in India initiative, he's trying to make it more economical. But as of now, we feel this, even though it is not specific because it's just a blood-brain barrier breach detection, it helps in a way that the visibility of normal brain to tumor is excellent. Of course, photosensitivity, as he mentioned, is not very common with these cases, but even irregular tumors like this with peripheral enhancement can be removed, and it can be used in a variety of tumors, even benign lesions, as against ALA. The infiltration zone in ALA is a little dangerous. One has to be careful because the metabolic uptake in infiltrating zone, if it overlaps over a functioning zone nearby, can be there. So when you are doing ALA, it's always better to do along with monitoring, especially if there is infiltration towards the area. I'll just show you an illustrative video of both just to show the comparison. So you can see here it's very dark. You can't see normal brain, whereas here it's quite nice and bright. You can see very clearly tumor, which is clearly fluorescing separate from the normal brain. So it makes life much easier to resect this and have excision rates like this pre and post-op with fluorescent guided resection. And even in complex areas, you can have good resection like this with yellow fluorescence. And our own study of about 30 cases, we found gross total resection could be achieved in more than 90% of cases with intraop imaging too. Coming to intraop imaging, once you have navigation, if you marry it with ultrasound, it's even better. As Dr. Ali has already championed the cause of use of intraoperative ultrasound, you can see that it gives good imaging, whether you have navigable or just a 2D ultrasound, it doesn't matter. Keep using the ultrasound so that you can see the margins clearly, except for this small 5mm margin area where you may miss a low-grade tumor. Rest of it has been compared in studies and given good outcomes of good resection. And this can be superimposed with the pre-op MRI, which makes it more informative, which makes it also informative to combine along with the DTI tracking. So this is showing such a case where we have incorporated tumor, DTI tracking, intraoperative ultrasound showing residual tumor out here, which is also finally resected, and the cavity is clear of tumor with preserved DTI represented tracts. Very irregular tumors, large tumors, I feel intraoperative imaging like intraop MRI is very useful. So you can see large cavities like this can be created safely without a deficit in these patients so that they don't land up with deficit, especially insular lesions, especially recurrent lesions where there may be a problem in identifying preoperative tumor versus post-radiation changes. So Last is the peritumoral edema, where there is a lot of reports showing the more you resect them, more than 50% of T2 margin. So this is something which is possible only if you have an intraop MR guided resection, that you can target 50% of the peritumoral edema and resect. This is the pre-op and this is the post-op with peritumoral edema resection. So the intraop MR guided sections have consistently shown, even in level 1 study, more than 40% of cases residual tumor in the intraop MRI is seen after the primary resection, and 90% plus resection when you use it significantly. So in conclusion, I would say navigation, DTI, least accuracy, but mostly available everywhere, and it gives very valuable directional information. Intraop neuromonitoring is very demanding, most accurate functional information, negative mapping for resection margin, important, enhanced utility in combination with some imaging. So it will be more useful. Fluorescence, we find it useful in contrast enhancing tumor. ALA is useful, but functional margin with infiltrating areas needs a caution. Ultrasound definitely is much more easily available. It's real time, much more informative, works well in almost all cases, and it can be used as a real time imaging agent before doing the MRI to confirm whether the tumor has been resected completely or not. And intraop MRI is actually not that expensive if you see, if you can make it a hybrid unit where the radiology can utilize the theater, the MRI suite for doing diagnostic MRI. It doesn't work out expensive to the operative patient who can be wheeled in from the OR into the diagnostic room and the MRI done. It's just a pre-construction event that has to be coordinated with the hospital. It is time consuming. It can work very well with intraoperative ultrasound, but given the fact that it is the gold standard, in some of these patients, especially low-grade gliomas, having them resected, even at the cost of a little extra time, may be much more valuable years to the patient. So coming back to my original slides, so T2 flare abnormality like this, as I said, you can go around the tumor and resect if there is no eloquent area around. You need not have to do complex monitoring. Maybe navigation is good enough. Deep-seated lesions, you may need some form of imaging, fluorescence guided, and lesions with a lot of edema. The intraop monitoring is going to be very difficult, but intraop imaging will be very useful. But intraop monitoring is absolutely essential in areas which are near eloquent areas or presence of eloquent areas. So in conclusion, in spite of successful medical trials, even with the IDH antagonists that we are seeing now, resection is still the significant prognostic factor. So we should do everything in our control to have a resection, but it should be safe. Don't forget KPS is also an important factor. So any factor that's likely to affect KPS should not be compromised. For that, a good pre-op planning of a resectable lesion, please choose your case. Advanced imaging is very important so that you're more armed with more information, better for the patient. And use all adjuncts at your disposal, whatever you have. They could be complementary to each other. No one is superior to the other. And please do post-op imaging early so that you can have good learning from what you do over a period of time. With this, I thank you for your attention, and we can take any questions or discussion.
Thank you, dear Anand, for that wonderful presentation. You have rationalized the entire gamut of glioma surgery. You have shown what is possible and what is contemporary and what is probably futuristic, and what is good and what is not so good, and what is not required and what is required, and what is probably the best. So all in all, I'm very happy to hear, and I'm sure all those who are hearing will be educated with your presentation. And as you know, this presentation is being relayed quite far and wide, and many people are hearing what you have said. And my best wishes to you, dear Anand.
Thank you.
Thank you, sir. Let's move on to the next one. We've seen anatomy, function, surgical technique. So we are now moving to judicious use of molecular markers in routine neuro-oncology. I would like to invite Dr. Rakesh Jalali, who is the lead at Apollo Proton Center, Chennai, and he's also now the president-elect of the Asian Society of Neuro-oncology.
Thank you, Abida. I'd like to begin by expressing my gratitude to Professor Goel for not only starting this wonderful forum, and he chose neuro-oncology. That's very pertinent and very important, as we have heard all during the webinar. But I'm also particularly grateful to him that he has included somebody like me, who is not actually a neurosurgeon, but into this forum, and it is an honor and pleasure to be part of such august gathering. Because the topic was on neuro-oncology, I thought the first slide should be that we have actually for the last 20 years or so collected fair amount of data, both from the neurosurgical oncology perspective, but also from the adjuvant perspective, the demographic perspective, the molecular information that I'm going to show it in the next few minutes. But this is a very old slide, basically trying to demonstrate the differences of demography in common tumors. And we talk mainly about the gliomas at the moment, and this was our initial cohort when I was working at Tata Memorial compared to the Western data of Central Brain Tumor Registry of the United States. And several of our colleagues from different centers like NIMHANS, Bombay, and also in All Institute of Medical Sciences have demonstrated the same. If you look at any parameter of survivals, year survival, even 5-year survivals, not only in glioblastoma, but different gliomas, whether they are integrated gliomas, pediatric gliomas with oligodendroglial component, pontine gliomas, more or less we measure up with the Western world. And as far as the adjuvant concerned, the radiation and the temozolomide in particular, I want to highlight that our temozolomide, we have number of generic brands, 1/20th of the cost of the innovator, and yet the median survivals are practically the same as you would expect any part of the world. But at the same time, we must be cognizant of the diverse population that we have, and also the diversity in the cancer care, including neurosurgery, and also the neurosurgical oncology. The number of neurosurgeons, the number of oncologists, the access to care, the affordability, the social stigmas that are associated, lack of dedicated neuro-oncology setup, the lack of multidisciplinary joint tumor boards, highly skewed oncologists and neurosurgeons to patient ratio, lack of physical, social, emotional rehabilitation. And then in India, we have this interesting paradox that a good percentage of the patients, can have access to vast amount of medical facilities, but there's a small percentage who can afford actually anything, but also a good chunk of the patients may not be able to have access and affordability. But at the same time, the Indian story of neuro-oncology, particularly from the rapid change in neuropathology and molecular markers, were conscious of this effort. And several years ago, our colleagues, we published the data on the ISNO classification of the 2016 neuropathology update, which was kind of a revolutionary at that point of time when we published that data set. Now, of course, we are moving now to the latest WHO CNS 5. The 5th edition, the formal edition, the 16 was only an update, not the edition. And in general, the changes are, there are new recognized types, very important, and also from our colleagues from neurosurgery, the Arabic numerals are employed instead of the Roman numerals because there used to be sometimes some errors in it. The taxonomy has changed. We know that the layered integrated diagnostic systems remain the same. As far as the gliomas are concerned, very important point is actually they have been classified as adult types and pediatric types. And interesting to note that they are not called adult gliomas or pediatric gliomas. They are called adult types and pediatric types, giving the connotation that an adult type could also be sometimes in the pediatric or adolescent and young adult population. Conversely, a pediatric type may be sometimes seen in adult because of your unique pathological, clinical, as well as molecular characteristics. Actually, the 21, in my opinion, has become simplified as compared to 2016, which was quite a bit of revolutionary change. And we also know the differences. This is just a snapshot of the adult diffuse gliomas. There are only actually 3 now. All the astrocytomas have to be IDH mutant. Oligodendroglioma has to be IDH mutant. They also have ATRX retained and also harbor 1p19q code deletion. If they have grade 4 component like necrosis and MVP, we don't call them, but are IDH mutant, we don't call them glioblastoma, astrocytoma grade 4, and all glioblastoma have to be IDH wild type, and this is very important. And there have been some different types in diffuse low-grade gliomas, both in pediatric type as well as the pediatric high-grade gliomas. I touch upon some of them with case examples. And this is relatively simplified classification of circumscribed tumors, pilostic astrocytoma, but mind you, there could be also a high-grade glioma with pyloid features typically seen in young people in posterior fossa, which WHO says is at least grade 3. 34-year-old lady presented with high-grade glial tumor, left frontal lesion, had oligo cells, had ATRX retained, 1p19q co-deleted, IDH was mutant. We call it grade 3 oligodendroglioma. Now, here you will realize that I have not used the Roman numerals anymore. It's the Arabic numeral grade 3. Now, the point here I want to make is that in spite of being a high-grade glioma, or glioma, particularly therapy after surgical resection, has an excellent outcome. Median survivals are exceeding in decades, both in grade 3 and grade 2 can be even more. And that is quite heartening. So this has practical implication. Number one, some of these oligodendrogliomas can actually be quite deep-seated. They can be in the insula, they can be near the corpus callosum, they can be in the cingulate gyrus. And if you have ways and means to determine preoperatively that this may well be an oligodendroglioma, you perhaps need not to chase up every single bit as you would probably chase an astrocytoma or a diffuse glioma. That doesn't mean you just do a biopsy, you try to remove as much as possible, but at least you have this luxury that the adjuvant treatments will work quite well. And also, interestingly, in the post-treatment sequela, if you see some enhancement, particularly in the periventricular areas and this connotation, and if it is an oligodendroglioma confirmed with the molecular pathology, please be careful that it may not be a recurrence, likely to be a treatment change because of their excellent outcome. And also the imaging biomarkers. I'm becoming fascinated with radiomics, that we have this classic T2 flare mismatch sign in gliomas now, particularly representing IDH mutant astrocytomas. And if you, for example, you can see the T2 is quite bright here, hyperintense, and T2 flare is dark, so it's an astrocytoma, like unlikely to be an oligo. If there is no mismatch, likely to be an oligo. This all operative to some extent. Our group, both in Tata Memorial and now in Apollo Proton Center, we have tried to work in different series in medulloblastomas, machine learning. Recently, in Nature, scientific reports from the Proton Center, where Dr. Rupesh was also one of our co-investigators, we have identified a unique biomarker in pilostic astrocytomas of an perfusion modality of APT mismatch with ASL, and it has been increasingly studied in other centers of the world, as I understand. Now, second case is actually trying to demonstrate the benefit of molecular classification. Now, we have had these glioblastomas who we have all anecdotes, somebody living for 5 years, 10 years, 7 years, 8 years. This is actual case of 42-year-old, March 2016, was called glioblastoma, received standard therapy. After about 4 years of relatively long DFI, had a recurrence, re-excised, we gave a re-radiation with proton. This pathology was epithelioid glioblastoma. Now, epithelioid glioblastoma has been increasingly recognized, is part of the WHO CNS 5 2021. 16 was not the part, it was the suggestion that they are IDH negative, ATRs retained, but 80% of them will have BRAF V600E positive. And it's a relatively simple IHC marker. Doesn't cost much, hardly 2,000 to 3,000 Indian rupees. And you can make a big difference because if they have V600E positive, they have also a classic radiological markers. They are typically cortical, they have some hemorrhage, can be seen in young people, occasionally can be seen in older people with relatively aggressive leptomeningeal metastasis, but some of them actually can respond very well to BRAF inhibitors. And we have just published our initial series on the BRAF V600E mutation from the Apollo Proton Center using a BRAF inhibitor called dafrafinib, but also what we call MEK inhibitor of trametinib. And this patient is doing really well. And now we have a follow-up in January 25 as well from 2016, relatively long DFI. And you have to identify this cohort of patients where the prognostically and also therapeutically, along with your oncology colleagues, the neurosurgeons, can make a difference to the patient. There are two data sets which I share. The Lancet Oncology a couple of years from Patrick Wenn's group, what is called ROAR study, that it was called what we call tissue agonist. Doesn't matter what the pathology is. It can be pleomorphic xanthoastrocytoma grade 3, which about 60 to 80% will have BRAF mutation. Anaplastic gangliogloma, erstwhile called, we don't use the word anaplastic anymore, gangliogloma grade 3, can also have a high risk of BRAF mutation. But also in children where there are deep-seated optic pathway gliomas, and also sometimes in adults, they can have even pilostic astrocytomas. If you use MEK inhibitor, they can have very good data and very good outcome, and you can avoid very radical surgeries and very potentially damaging radiation therapy in very young children and these young people as well. So this is an adult study, the ROAR study, and the New England Journal of Medicine paper last year showed in the pediatric population favorably compared with conventional chemotherapy. The third case I wanted to show you was a rather unusual, we thought it was a glioma, and this was actually we're wondering whether it is a pilostic astrocytoma in an 80-year-old boy. Walls would be high-grade glioma. The walls were enhancing, but largely cystic, and many eminent pathologists of the country, both the parents were physicians, very eminent physicians of the country. We ranged from pediatric high-grade glioma to what we call diffuse hemispheric glioma and G34, which is Fluorescence, but those were negative. We call them G34R and G34V. And the classic feature was ATRX was lost, and this kind of raised a red flag. And we also do OLIG2 very commonly. Please, I would request all of you to construct GFAP, and GFAP everyone knows, but OLIG2 is a very important marker. Again, not expensive at all, and they should be in the armamentarium of every single neurosurgical neuropathology lab. So we thought we will treat as a high-grade glioma. We treat with focal RT, with temozolomide, but we sent it for what we now call DNA methylation, and we have to understand this process a little bit more. It's quite challenging both to perform the test, but also financially, and we are trying very hard to get some sense of DNA methylation in our country. And to our utter surprise, it came out to be what is now WHO recognizes an embryonal tumor, not a glial tumor at all. It was called FOXR2 neuroblastoma. And you have to look at, basically, it's a huge library of cases. There is a Heidelberg group, there's a Toronto group, there's an NIH group. There are 3-4 groups, and they just kind of classify and try to get the molecular information and the genetic information as close to what you match. And any match more than 0.9 is pretty good. Here, the match was actually fantastically well. It was 0.99. So it had to be a FOXR2 neuroblastoma. And the funny part was that the parents, we were telling them it was a high-grade glioma, probably a GBM. And the FOXR2 neuroblastoma actually has a 5-year survival of 75%, a complete change in the prognosis. And as we learn more and more about these unusual cases, and we learn more about the molecular pathology, as I think Dr. Moyadi also mentioned, come together to look after our patients better wherever it is possible. Now, the histone ones are two types. Many of you know the classic diffuse DIPG or pontine gliomas. Now we call them diffuse midline gliomas, can be in the thalamus, can be in the spine, can be in the medulla. And they have H3K27M altered. We don't call it mutation. There is a loss of trimethylation ME3, but M can be altered. And there is another molecular function called EZIP. But that, I think most of the people know. This is a little unusual. We used to call them actually diffuse gliomatosis, or sometimes we used to call them GBM with PNET features, like at the diffuse involvement, but they tend to be in the hemisphere. Very difficult to resect. You may be able to resect but you know that you are just doing the tip of the iceberg. There's a diffuse infiltrating component all over the place. Typically seen in AYA population, OLIG2 negative, ATRX lost, again, very important marker. Interestingly, 60% are MGMT promoter methylated, which is actually a good sign, as compared to about 30% of the routine glioblastomas. So many of these patients respond very well. They're slightly better than run-of-the-mill GBM, but eventually they succumb. The median survival is about 3.5 years, sometimes even less. So they are also incurable tumors. But there are two very important data sets that some of them have interesting mutation. For example, this is platelet-derived growth factor-related amplified, and there are drugs available now against this mutation. One of the drugs is called dasatinib. So we are trying globally, to look at the mutational profile of these patients, very high-grade infiltrative tumors, whether that can make a difference. And there are several clinical trials going on to address this issue. The final frontier, of course, as I mentioned, is gliomas against it. There's a tremendous amount of interest in CAR T cell therapy, which is a immunomodulation. And I suspect maybe in the next 5-10 years, we might get a small breakthrough. Otherwise, extremely difficult, challenging tumors where surgery has no role, radiation is largely palliative, and systemic therapy has more or less failed. The pediatric high-grade gliomas are a different kettle of fish. Many years ago, we published, before the molecular information came possible, we published our data of 66 children, but now we know there are 3 distinct subtypes. I don't want to bore with you details. The RTK1 is the platelet-derived growth factor, RTK2 is the EGFR, and MIC-C is the most aggressive one, and they have the worst prognosis. But I do want to present one scenario which is not uncommon in your practice, and it might resonate with Professor Goyal's earlier hypothesis and the interesting discussion about the nature of the gray and white matter delineation and how the glioma cells infiltrate along the different parts of the brain. Now, this is actually a relatively young man, 35-year-old, kind of a cystic lesion, actually, beautifully resected. Everyone would have given, oh, that's a very good prognosis. And IDH actually was positive, ATRX was lost, excellent resection, right-sided, non-eloquent, non-dominant, removed very well, RT given. Within 1.5 years, had a massive recurrence in both sides. And we ultimately lost this patient. And it seems, then it turns out that about 10% of so-called grade 3 and about 4% of grade 2 IDH mutation can harvest rather aggressive mutation called CDKN2NB, and they are now called molecularly defined glioblastoma. Even if they look like grade 2 tumors, it's very important for neurosurgeons also, because they may just give the prognosis, the patient is going to do well. But we routinely now do CDKN2NB. It costs about 8,000 to 10,000 rupees to do the test. And they are actually very, very aggressive tumors, almost like glioblastoma, even if histologically they look like grade 2 tumors. However, there is some rays of hope. IDH mutation is a glioma genesis gene. Recently, there has been a fascinating piece of work in low-grade gliomas where they have identified an IDH inhibitor called vorasidenib. And we are very excitedly looking forward. I don't want to go into details about this study because this was on observation versus the drug, but there is fair amount of excitement in the field that how to incorporate in these rather aggressive tumors, whether we can use it in grade 4 and grade 3 astrocytomas who are IDH mutant as well. And the next 5 years, I'm sure you will see more data on it. And final case of my presentation is an increasing recognition, at least in our group, and I urge and request all of you also to have some kind of data, especially in our country. In some parts and pockets of the country, we have a fair amount of consanguinity there. And this was a 9-year-old child presented with what again looked like a kind of a diffuse GBM with high diffuse pattern, multi-sensitivity, multifocality, hyperintense, non-enhancing, mind you. It was called high-grade glioma. And then we realized that that was a congenital mismatched pair deficiency, what is called CMMRD. It's a congenital association. And the microsatellite instability, their genome is very unstable, but they respond beautifully to immunotherapy. Otherwise, immunotherapy has largely failed in gliomas. But in this subset of patients, there is a fair amount of excitement. And in the next ISNO meeting in April, we are dedicating a 2-hour session exclusively of the role of immunotherapy in malignant gliomas. And this patient is doing very well so far because they had the MSI, and this recognition has to be there in that point. I just wanted to finish the glioma story, but the other common tumor where there has a tremendous change is medulloblastoma. I'll just run through the cases. This is our own work in Tata, both the safety profile. We are also looking at de-escalating in the Wnt pathway. Even the surgery, you don't need to chase everything because the survival is exceeding 95 to 100%. Small residual can be there near the CP angle. And we have also demonstrated the same in our proton services. But the last 1 minute is the diagnostic services at LMIC. As I mentioned, the services are diverse and it has of the world, but the Asian Oceania Society of Neuropathology is doing an unbelievable amount of work. They're adapting this WHO CNS5 according to the resource-restrained regions. And this is just a snapshot, and I'm sure this presentation will be available to people. And now if you look at actually just a marker, the pricing, except the DNA methylation and next generation sequencing, most of it is actually quite affordable. It is just the sensitization, and neurosurgeons play a pivotal role. They are the Abhida, can you see my presentation?
Oh, I can hear you, but the presentation just went off.
Okay, now can you see?
Not yet.
Oh, it was actually the final slide. Just summary points of the final slides were the development in molecular markers have been quite useful. The 21 update is a natural evolution of the classification. They are better understood, the gliomas, better managed in the current practice. It actually ties the neuro-oncology community, the neurosurgeons, neuropathologists, clinicians, the scientists growing together with growing collaboration. The pace of the development seems to be frenetic, however, can be intimidating to the clinicians, the pathologists, everyone, the surgeons and the physicians. But I think ultimately, if you do it judiciously and thoughtfully, incorporate into the practical guidelines and algorithms in your clinical practice, it will not only help the scientific community, but also eventually will help in managing our patients much better. And I do believe the Asia Oceania Society of Neuropathology, their adapter guidelines and recommendations, which is a work in progress, are very likely to address the growing need that we have in our clinical practice, such that we can judiciously and very carefully implement the scientific knowledge into routine clinical practice. Sorry about the last that you couldn't see, but with that, I conclude my talk, and thank you very much again for your patient hearing.
Thank you, Rakesh. You are undoubtedly our leader in the field, and you have been decorated radiation oncologist and a scientist and an achiever. I like to call you firebrand person, firebrand. You not only work like a brand ambassador of India, but you have some kind of unique fire in you, which many, I will say that this kind of characteristics that you have is a surgical characteristic. If you were a surgeon, I believe you would have gone places and we would not have found space in your presence. But what you have shown is, normally I cannot understand the language of molecules and all those things, molecular pathology. But every slide I was carefully, I was actually little bit fearing not to miss any sentence that you taught. All in all, Rakesh, it was a great presentation. I think you made it simpler for neurosurgical audience, and it was very highly educative and informative. Thank you very much, my dear Rakesh.
Thank you.
So moving on, sir, Dr. Sridhar has just landed late, so he will not make the presentation. So I would now like to invite Professor Atul Goel for his talk. Sir needs no introduction. As everybody knows, his philosophy of neurosurgery and technique has impacted every arena of neurosurgery, be it skull base, be it craniovertebral junction, and now it is going to impact glioma surgery. So welcome, sir, for your talk.
You can see my slide?
Yes, sir.
Yes.
Okay. So first of all, thank you, John, for organizing all this. And thank you for educating the world in the field of neurosurgery. And I'm very happy to be proud of your shows for last several years. And I counted, John, I have presented, more than 150 times in your shows over the years. And I think that is a good achievement by itself. You agree, John, on that? Anyway, glioma is a subject which is ingrained in every neurosurgeon. It is a part and parcel of neurosurgery. Every neurosurgeon has to understand, has to operate on gliomas. Gliomas and meningiomas form a part of our life, and we take birth in the field of neurosurgery by operating on gliomas. We grow in gliomas, and we try to understand more and more, but it is difficult to reach the destination of understanding gliomas. And we have written several articles on the subject. Glioma has been in neurosurgery for several decades. And I must tell you, in the 4 decades of my journey in neurosurgery, I have operated on several hundred gliomas, and I have been trying to understand this difficult subject. Klinger is one gentleman who did very beautiful fiber dissections of the brain, and these dissections form a very important part and parcel of understanding and treating gliomas, particularly in my way, as I'll describe. So high-grade gliomas are, it has been a subject for junior neurosurgeons, for residents and things like that. And we have learned how to achieve hemostasis, how to remove the tumor, how to find the plane of dissection and things like that on high-grade gliomas. But as I grow further in the field of neurosurgery in general and high-grade gliomas in particular, my feeling is the stakes are little rather too high in these kind of tumors, because these patients have a very short span of life left, and in that short span of life, if you create any kind of deficit or hemiparesis or speech disturbance or higher function disturbance, you have created a disaster, not only for the patient, but for the entire family. So the bottom line in treating high-grade gliomas is to assure yourself and the patient that there will be no complications. Of course, in our subject of neurosurgery, complications have to be there, and we learn from our complications, but complications can be devastating in these tumors. And how much we are helping by radical resection, nobody actually knows. My subject today is essentially on low-grade gliomas. In my journey of neurosurgery, I must tell you that not even 15 years ago, these tumors were not treated because the symptoms were marginal, some convulsion here and there, some memory disturbance, little bit here and there. But essentially, the person was walking and talking and all those things. So we knew that this is a low-grade glioma. So biopsy also was not necessary. We also knew that this is a low-grade glioma. Adjuvant treatment may not be good. So these patients were not treated at all, and they were treated symptomatically. But over the years, with the teachings of several heroes in this subject, we have now concluded that radical surgery is good for these tumors. These tumors have been called diffuse, invasive, infiltrative. These terms by itself negate a very radical resection, negate the possibility of radical resection, and approach has been rather conservative and not very aggressive for a long time in my own journey. However, now everybody in the world is convinced that low-grade glioma radical surgery is good for the person. And I will say my personal interaction with Dufau several years ago in Japan, we had a good discussion with him. I had a good discussion with him, and my very aggressive approach towards him was that no, these tumors should be just biopsied if at all, and nothing should be done, and this and that. This was about 20 years ago with Dufau. But he was categorically saying, no, these have to be resected and this and that. And now I see that how much true he was. Radical resection relieves symptoms, it reduces tumor burden, it improves quality of life, it improves the symptom. You see, person comes with headache, person comes with convulsions, person comes with higher function disturbances. Headache is a constant symptom, maybe mild, but it is there. And these symptoms can be reduced and dramatically reduced. You see the face of the patient before operation, you see the face of the patient after operation, much different. They become different and they become happier, and the longevity of life increases. And more importantly, now several studies have come where the malignant transformation of this tumor is also supposed to be delayed by radical tumor resection. So this is the current standard of low-grade glioma surgery. And if you really ask me in neurosurgery, what has progressed in the last 20 years? What has progressed is how to do radical surgery in low-grade glioma. That is what has progressed. Various kinds of neuromonitoring has come in, intraoperative imaging has come in, preoperative imaging, functional MRI, DTI of various kinds, intraoperative dyes that we have heard today, connectome theory, which is now becoming very popular and very well received by the neurosurgical population. If you really ask me what has actually progressed and what has been defining and what has really changed the face of low-grade glioma surgery, and particularly my own evaluation of the subject, is understanding of fiber tracts. And these fiber, when I joined neurosurgery in 1982, more than 40 years ago, as a very young boy, we never used to talk of white fibers. We did not know, our books did not have the mention of white fibers. Only frontal brain, parietal brain, temporal brain, motor strip, speech area, and these were the kinds of things. White fibers is a relatively recent introduction, and we know that how Yasser has promoted the understanding of white fiber and how subsequently many groups have promoted the understanding of white fibers. And in our own department, we have written several articles on the subject on white fibers. And understanding these white fibers, I have been personally involved in dissection of white fibers for several years, and I have realized that understanding of these white fibers completely can change your concepts regarding glioma surgery in general and neurosurgery in general and glioma surgery in particular. Pape's circuit, brainstem anatomy, you see how the white fiber, we never used to know about how these kind of beautiful dissections were even possible when I joined neurosurgery. We divided white fibers into various groups: superficial group, middle group, vertical fibers, and you see this classification that you are seeing of white fibers according to how they are located, how they extend, and how they function. If you ask me what has been my work on real, you see, I was in skull base, I was in craniovertebral junction, glioma, I was doing all the time, but real thing which I got suddenly out of the blue was understanding of the fact that gliomas are confined tumors. Surgically, not histologically and all those things. You surgically, they look different, they are different. They are confined to a white fiber tract, named white fiber tract. They grow along the white fiber tract and they create dysfunction by pressing on the adjoining white fiber tracts, by deformation, and very rarely by destruction. But deformation is the more important, pressure and deformation. And more importantly, for a surgeon, by virtue of color, by virtue of consistency, by virtue of vascularity, by virtue of seeing the adjoining brain, you can develop a well-defined plane of dissection. And I must also tell you, as my journey with these gliomas continues over the years, I am getting more and more and more convinced about this concept. Dufault says, I don't need microscope, I don't need this, I don't need that. We have already heard from him several times. Now what I am realizing that many of these tumors, gliomas, you don't even need awake craniotomy. You don't even need any kind of monitoring. Not all, don't misunderstand me, not all. Some of them need, of course, and some of them need very badly, but many of these tumors don't need, and you can have a very quick fire resection, and you can do en masse tumor resection in a number of clinical situations, not all. And this article was published some 4 or 5 or 6 years ago. Now our series has gone far beyond. My concept has become more solidified and more ingrained, and I'm much more comfortable when I do these gliomas. So we divided gliomas into 2 groups. One is this short arcuate or localized, arising from the short association fibers, and one is along the corpus callosum or diffuse, which go along the length of the brain. So diffuse and localized glioma, this was a small classification that we introduced on the basis of the extension of low-grade gliomas. So when you see this kind of corpus callosal glioma, this is not a haphazard pattern of extension, which we always see, oh, it is here and it is there. This glioma is along the fibers of the corpus callosum. And there is a big possibility of designing a plane of dissection around this tumor. Of course, the anterior cerebral artery has to be taken care of and things like that. But the extension of this tumor is along the named white fiber. And we wrote this beautiful article that we can actually say that this is a glioma or not on the basis of if it is going along the white fiber, it is a glioma. If it is not, it may not just be a glioma. And also you must remember that white fibers are having a very elaborate extension in the brain, like corpus callosum. I never knew corpus callosum can extend through the breadth and length of the whole brain. So you must remember that if you see it is extending along the length and breadth of the whole brain, does not mean that it is, a different kind of glioma or whatever. We have to see the tumor, and you can identify from which named white fiber tract it is arising from. Now here is the tumor. Everybody in the world will agree that this tumor located in the supplementary motor area is a dangerous tumor to operate. Now, if your concept is like, of course, awake craniotomy may be good, but this patient, I remember, was not under any kind of awake situation. Concept of localized tumor, confined tumor, and that I can see the tumor from the adjoining brain and develop a plane of dissection. Now, what I want to show you is quickly, because, I want to show you several cases if possible. Just see how I am, this tape was actually unedited tape. And this whole tape was 7 minutes. The whole operation was done in 7 minutes. And if you realize how I am, how I am making a displane of dissection from normal and abnormal. And this is with the suction in my right hand. It is not only just designing a plane of dissection in a very, very critical area of the brain. You must remember that if I create hemiplegia, then I will not excuse myself, and patient will never excuse through his life. And nobody is allowed to create unless you are convinced that this is what, and this is how the tumor is going to extend, and this is how you can achieve a radical tumor resection. If you see the dissection, of course, I cannot show my 6-minute or 7-minute dissection, but there was not a single coagulation in the whole story. You have to, of course, coagulate here and there, but by virtue of consistency, by virtue of normal and abnormal, and designing a plane of dissection. So let me show you another case. This is the tumor, and this is the tumor in relatively less formidable, less dangerous area. But I want to show you how I'm designing a plane of dissection. I have a little bit edited here, but you see how the dissection plane is being designed. There is bleeding going on here and there, but very, very little coagulation. You see how the dissection plane in a tumor, which is now, if you wish to have monitoring, if you want to have awake situation and all, you can certainly, but what is I'm showing you different is I am doing this tumor surgical. I'm not saying histologically they are in this location, they are not a millimeter has gone here and not a millimeter. After all, these are cancerous tumor, and you have to agree to that you cannot cure these people, but surgically you can make a radical dissection And my feeling is, of course, functional mapping and all those things and monitoring and all those things are necessary for more critical areas. But, and if you say that the tumor is extending far beyond this, and maybe if you do functional mapping, you can do more resection. To tell you the truth, I don't believe in those kind of concepts. My feeling is look with your eyes, identify the tumor from abnormal, I have the understanding that these tumors have different consistency, different vascularity, different format of dissection, and you can develop a plane of dissection. You see how I'm designing this plane of dissection. And if you have, I have not shown you the entire video, but this video also must not be more than 8 or 10 or 15 minutes. The entire surgery can be done beautifully, radically, if you agree with this concept of radical low-grade tumor surgery. And as I have mentioned, as I grow in this field, as I understand these tumors more and more, and this kind of radical resection has now become a norm in my operation theater. Critical areas, near the motor areas, of course, I will like to do awake situation, but awake craniotomy can be avoided in a number of clinical situations. Now I want to show you another tumor. Do you see this tumor right in the region of premotor area, precentral sulcus and motor area? Dangerous area. No glioma surgeon will ever say this is not a dangerous area. And if somebody says it is not a dangerous area, he does not know the brain. So it is a dangerous area. You agree. Now, if you have the concept that even if it is a dangerous area, see, this is the tumor and this is the normal brain around it. And I have to work in a very, very critical area. And I have to tell you that these tumors are the most dangerous tumors in neurosurgery because these are low grade, number one, and you create a deficit like a possibility of huge deficit like hemiplegia is there. So you cannot have, and I must also tell you, in our field of neurosurgery, complications can happen and complications will happen. But if you have a concept, if you have an understanding, if you believe that understanding, then you go and work with this kind of understanding. So in this criticalest of all areas of the brain, in the region of motor strip, see how I will design a plane of dissection first in a relatively safer area, identify the tumor, and this tumor also, you see how, and when I do this suction, don't think I am doing suction. This is not a suction. This is suction plus dissector plus knife and plus all those things that you can imagine in neurosurgery. And also what I believe is number of times you coagulate in this area, and here this is the motor strip. To see I'm avoiding the motor strip little bit. I'm going in the tumor to dissect inside the tumor, but essentially the whole thing in the most critical area of the brain is being removed in real time. I'm actually little bit, whatever bleeding you're seeing is of course going on, but there will be no instrument like bipolar or any kind of instrument. It will come here and there, but not much. And this is the patient post-operatively during the COVID times. I did this case and you can see the patient. And I must tell you that these patients, if you are not convinced with this philosophy, if you don't have the technique of dissection, you're not allowed to do because the complications can be disastrous. And you have to have the concept and you have to be convinced with this concept that this kind of radical resection and mass resection can be possible in the most dangerous of neurosurgical areas. Now, this is a huge tumor. I will say I don't need any kind of monitoring for this person. And this tumor has been removed. Even this huge tumor can be removed by consistency. And if you realize, if you go more into this subject, you hold the tumor in one hand, it is almost like you can pull you can pull the tumor out of the brain. It is possible, and you can have that feeling. Here is another tumor, which is relatively complex area. Majority of the tumor has been removed en masse, and you can see this post-operative situation. Essentially, what I'm saying is that I am not saying I am curing them. I am not saying I have removed every bit of the tumor. I am not saying this tumor, no cells are beyond this. I am not saying that this tumor has gone far beyond and here and there I am removing. But what we see, we do. If you say I will depend more on functional mapping and I will see the function and I remove more brain, I have a feeling that what you see, what you do, and don't go for too much on a patient who is in a very dangerous kind of situation. His brain is being dissected upon. He's hearing all the voices of the operation theater. He's hearing the suction. He's hearing your noise of your bipolar. His mental faculty is not all that prominent. You depend on your high power microscopic vision and remove these tumor. And this is another huge tumor which I removed quite radically, essentially en masse. So this en masse strategy, which we described about 4 to 5 years ago, now the concept is developing and becoming stronger and stronger. And this concept, it was first introduced by us in the literature, and many people have referred to this, and many people have, when they don't refer, then they get a letter to editor from me, and then they respond and they say, yeah. So this is another tumor. Now you see the color, the consistency is different, some kind of bulge in the brain, and you see this color is different. Low-grade gliomas are different color. Low-grade gliomas, this is one whitish, may not be this color, but consistency by vascularity, you can have a beautiful plane of dissection, and you can get the tumor out like a very solid kind of a tumor. So this is another dangerous area, as you can imagine. And work from the less aggressive area. Maybe this patient, if we want to have awake situation, may be good. I don't think this patient was done under awake condition, but could have been done. I don't remember this. Many of these more dangerous tumors, I like to do under awake situation because, you are more happier in the operation theater. You can be convinced with a philosophy. You can be convinced of some kind of concept, but you cannot create a disaster because you know that this disaster can be absolute. And to avoid that kind of situation, you might just like in this area, but not even in the frontal area, you want to do away. This is completely, not in my books. It may not be a good idea. So this is the tumor, this is postoperative, and this is another tumor. You see, this is a tumor, dangerous area, and this tumor has been removed beautifully and very positively. Now, how much is the extent of resection? What are the fallacies of radiology in evaluating? So what I do is, whether flare is good, whether flare is indicator, these are controversial issues here and there. But when you go, you see what you see under very high power microscope and magnification. Have a control of your suction and remove this tumor. And you can remove big tumors, dangerous tumors. Another thing which I was mentioning is high-grade gliomas. High-grade gliomas are high-grade by virtue of their multiplication factor, but they still remain confined. You evacuate the cyst and you can remove the tumor around, circumscribe and en masse. This is a big possibility, and this is not what I was doing. Dr. Dastur, if you know, Dr. Gajendra Singh, if you know, very famous Indian neurosurgeons at that time. And this is what he was showing me, Dr. Dastur, as how he is removing high-grade gliomas and mass kind of story. So this is another tumor, dangerous areas. But you have to understand white fibers. You have to understand how they will be dislocated, how they will be displaced, and what fibers you have to avoid during surgery, and what are the relatively dangerous areas of surgery, and then you have to go and remove this tumor. This is another big tumor you can see, and this is, I don't remember what I have done and how I have done, but what I must have done is en masse resection of this tumor, and that is the norm in my operation theater now. This tumor, I will say that I may not need. I will say one tumor which I worry, one area of the brain which I am worried the most. Of course, supplementary motor area is one area which we worry, and every one of us are worried. But the left parietal and posterior parietal and high parietal tumors are ones which I worry the most, because a little bit functional deficit can be quite devastating in these tumors. As regards insular tumor surgery, I heard one of the best presentations I have ever heard on insular tumors from Sushant, and I can only wish him best, and I am sure he will show more colors as he as his feathers become more brighter and fairer over the period of time, that insular glioma surgery is based on one subject. That subject is understanding the white fiber relationship in these tumors, understanding how the IFOF will be going, understanding how the uncinate fibers will be going, understanding how the commissural fibers will be going, understanding how the visual tracts will be trespassing this area and things like that. And then you have short arcuate fiber, association fibers. These things have to be understood. Most important issue is insular tumor surgery, that you have to save every single blood vessel. And if you take one vessel, you can have a devastation at hand. I will like to show you quickly this tumor in the Broca's area. And every one of us understands that this is the most critical area where we are going to operate. Any kind of speech deficit can be absolute. You are agree. Everything speech deficit is absolute. Now I will show you this patient. I wanted to do awake like every time I do in this area, and everyone in the world will do awake. But this guy was so much hyper that he will not allow an awake surgery. And I will show you how I did this with my concept of en masse tumor resection in this most dangerous and criticalest of all areas of the brain, and that is Broca's area. Now, Broca's area also, Dufau has shown us that there is a lot of malleability and suppleness and displacement of Broca's areas and things like that. You see this tumor also, if you realize, and I have already mentioned that not one single arterial vessel has to be coagulated. If you coagulate, you are done with. You can have a hemiplegia at hand. Not just speech deficit is one thing, but hemiplegia, and you have a person who is not only not speaking, but also not moving, and they will move you and shake you for the rest of your life. So this is the tumor, and I want to just show you how I'm designing a plane of dissection in this most critical area of the brain. And you see now here, I just want to repeat this. You see how this lip of the tumor is entering and going right into the brain surface. And this is the tumor, and how this en masse kind of resection is being done. And radical tumor resection, if we agree that radical tumor resection is needed, this is the way it has to be done. Now you go on mapping and go on doing all. Awake craniotomy is the only thing that I will depend on, and awake craniotomy will be the one thing that will help me during this kind of operation. And if you see this in the Broca's area, how this tumor has been dissected and has been resected and has been, probably this guy, as many people say, has been cured. Now the thing is, this area tumor, you have to have the concept that this is the way this tumor will, unless you are completely convinced, you are not allowed to do like this. And you see every single perforator and vessel has been saved in this operation. I am not sure, but I think not once a coagulation has been done. So this is the boy who is speaking quite okay now, still after operation. But I will go further. Insular tumors, we have done several, and you will very soon see our experience in print very soon. And these are the corpus callosum, as I mentioned, is a infrastructure of the brain. It extends here, it extends there, it extends over the ventricle, it extends right through the parenchyma and forms the foundation of the brain. And the tumor extends along the corpus callosum, along the fibers of the corpus callosum. And these tumors, one has to really understand the white fiber anatomy. If you don't understand the white fiber anatomy of corpus callosum, you will probably not be able to do. And this article from our group was one of the most fascinating articles on the subject, now a very highly cited article on the subject. And I wish you see this and do the dissection in your own departments. And this is the tumor resection. This is another huge tumor resection. We talked about orbital cortical approach for deep-seated tumors, and we recently analyzed the anatomy of this approach. this is the tumor. How will you approach? Whether you come interhemispheric, whether you come from frontal, we use transorbital cortex approach. We avoided the various white fiber tracts in this region, and on the basis of that anatomy, we designed this approach, and various parameters we have described as to how to enter and how to resect. Essentially, what the understanding is, white fiber is the key. Evaluate the tumor radiology, it will be in a pattern. There is a method in the madness. There is a pattern in the strategy, and you have to develop, understand, exploit that pattern, and do a radical tumor resection. So thank you very much, my dear friends. I hope this concept, which has now completely ingrained in my mind, will form the future of glioma surgery. The bottom line is this kind of dissection, this kind of holding of instruments, holding of one hand, suction in the right hand, suction being used as a dissector, suction being used as a scissor, suction being used as a retractor. This is what my feeling is. Identify the consistency, save the vascularity, and save the function of the patient. Thank you very much.
Well, you know, Abby, let me just say the 4 words I've been waiting to say for a couple of weeks. The king has spoken.
Yeah, my dear friend, yes.
Okay, the floor is open. Okay.
Any question for me?
Yeah, Pragnesh Bhat has a question. Go ahead, Pragnesh.
I just want to compliment Professor Goel on all the speakers for an excellent masterclass on malignant and low-grade gliomas. Thank you very much. It is 3:15 in New Zealand, and I will go to bed now after a sumptuous academic feast. Thank you.
Thank you, Pragnesh, for participating in this program. You, no matter where you are, whether in New Zealand or whether in Australia or whether in England, but you will belong to us and you will belong to Rajkot and you will belong to my place. Okay, Pragnesh? My best wishes. Enjoy your sleep. Good night. Sweet dreams about gliomas.
Thank you.
Atul.
Yes,
welcome, Harsha.
Yes, wonderful feast of the knowledge you delivered. And you are a last speaker, but you were the first speaker. You spoke last, you knew what to deliver. And what a way you are expressing your views to resect the glioma, whether it is a low grade, high grade. Impressive, very impressive. And I say one thing about you is you don't require any tools. All tools are in your mind. You know how to, where is the speech area and where is the fibers going. So you don't need that, I know, and I've seen you multiple times. Wonderful, wonderful. And it was a wonderful, all the speakers were superb and we have learned a lot as always. Very good, very good.
Thank you so
Congratulations.
much. Thank you very much.
Yandong, go ahead. Welcome.
Hello, my dear professor.
Yandong.
I have a question. Is the metastatic tumor share the same concept with the glioma? I just finished a case of metastasis the day before, and I find still the boundary is very clear. So I'm wondering, is the metastatic tumor share the same concept with glioma?
Yes. Metastatic tumors are also like a nodule. You can actually develop a very beautiful plane of dissection around a metastatic nodule, whether it is metastasis from the breast or whether it is metastasis from the lungs. These tumors are well defined and they sometimes can be very vascular. Sometimes they can be having a lot of edema around the tumor, but sometimes they are very highly necrotic. You first little bit debulk the tumor and then dissect the tumor around in like a nodule. You can remove metastatic tumor, Yangdong.
Yeah. In the past, my senior surgeon always said to me, the metastasis is there is no boundary with metastasis, and I just said to you I just finished a case of metastasis the day before, and the tumor is located at the submental motor area, a small, very small, only 2 centimeters. And I target the tumor. I begin the dissection. With at the first step, I split the superior frontal sulcus, and then I find the tumor, and then I do a very circumferential dissection of tumor. The boundary is really clear. Yeah.
Yes, Yang Dong. I hope you enjoyed the show, and I hope you got some beautiful messages. Yang Dong?
Yeah. Thank you.
Thank you, Yang Dong.
Okay, we have Liketh. Go ahead.
Prof, nice to see you. I'm from Glasgow, as you have met a few times there.
Yes,
It was fascinating talk, and I kind of was completely engaged in listening to all the speakers, from speaker one to your finale. So my question is actually because we've recently started using Fluorescence for IDH2s, but not 3s and 4s. So my question is, with the evolving, the drugs that can be used for IDH, inhibitors, is your oncofunctional balance shifting? Obviously, that has to be taken into consideration. I recently did an insular glioma, and then the fact that there is an option to give them, particularly the IDH, the grade 2 IDH mutant ones, where we could actually, reduce the amount of deficits just because there's something on the horizon. Would that affect your thought process? I'm just asking as a general question to all people who do low-grade glioma surgery with functional mapping. Is the future going to change slightly? I mean, the position of the oncofunctional balance needle, is it going to shift to the left?
You know what you have said? You have raised a very big issue. I hope Rakesh Jalali is there still on the horizon or no? Rakesh?
Yes, I'm here.
Rakesh, did you hear the question?
Yes.
So can you answer this question? Because, this is, I think nobody in the world can answer that better than you.
No, it's a very good question, and we are also seeing a spate of requests. We don't have Fluorescence as yet in India, but there have been a number of inquiries. But at global level, of course, there is quite a bit of interest because perhaps the first time, it has shown some promise. As you know, the trial was designed for very small tumors, low-grade IDH mutant observation versus the drug. There was also, it was not compared with surgery. And results actually, although significant, are not like dramatically impressive. There's only 24 to 27 months. It's about 2 years or so. So my suspicion is this is a good proof of principle study. And in some cases, of course, who are hesitant in a deep-seated eloquent cortex, young people, IDH mutant confirmed, it's a fair option. But whether it will dramatically change the neurosurgical practice, I doubt very much, because surgery does remain a very important point. Oncologically, actually, we are thinking that it might have more relevance on aggressive low grades. I mentioned briefly about CDKN2NB, aggressive variants of grade 2, grade 3 astrocytomas, even grade 4. And also the challenge is how to combine the two. There is some concern you can't combine with radiation, you can't combine sometimes with immunotherapy, you can't combine with conventional chemo, but next 5-7 years would hopefully throw some more light. So at the moment, in borderline cases, it definitely can shift your needle towards one side, but in whether it will completely obviate, I'm not so sure.
Thank you very much. I did think there was some kind of a selection bias, because if you look at the control group in that study, the median survival was 11, 12 months, which is actually far less than what we would get in a standard surgically resectable, grade 2 IDH mutants. So I think that there may be a selection bias, like you said, it is good for patients who are non-resectable. But as a surgeon, my principle is still go for the maximum without compromising too much of the function.
I
Thank
will
you very
also
much.
like to invite Ali. I can use the screen.
We have treated.
Ali, you're
I just
there?
want to make one more point.
Okay.
Ali, just one final point is, Dr. Likhit, is it somehow doesn't work in enhancing tumors, even if they're IDH mutant. So the data is only for non-enhancing tumors. So that's another kind of a conundrum into the mix. Dr. Moyadi, please. Ali.
Yeah. Yes. Actually, I was going to make the point. Dr. Jalali has kind of answered a lot of that. So as a surgeon, even though you have radiogenomics, you don't know whether it's IDH mutant or no when you started operating that patient a lot of the times. Sometimes there can be variations, and the post-operatively, it may not be IDH mutant. It could be aggressive CDKN2A, 2B. So I still think that going for the aggressive resection as we do even now with whatever philosophy, whatever tools you have, would still remain valid. And the second thing, I think more important, relevant in India in our resource constrained settings is that surgery still remains the cheapest option. The drug right now is beyond the reach for almost every Indian, I think. I mean, Dr. Jalali can probably tell us in terms of the cost and availability. And I think how long do you keep giving the drug? When do you stop? All those considerations with most, kind of therapies like this always remain. So I think the answer to the question is surgical strategy probably will remain the same unless something dramatic happens and we realize that we don't need to operate these patients at all. So that's the point I was trying to make.
Okay.
Yeah, okay. Go ahead.
Yeah, go ahead, Abby.
No, I think, sir, John has another webinar at 8. So I think, John?
Yeah, I'm glad to say I have another webinar from Mexico, but it's in Spanish. I don't know if you guys will enjoy that. But I'd like to thank Atul once again. A lot of interaction, a lot of attendance, a lot of attention. It's great you're bringing attention to cancer in India. You're bringing the latest information, and maybe we can make this a yearly thing. And thank all the speakers and Abby for putting everything together. Very well put, and thank you very much for the speakers. Long live the king.
Yeah.
Okay, bye-bye.
Bye-bye.